The committee will come to order. Today's hearing will focus on healthcare marketplace and how it's become more consolidated and less competitive in recent years, leading to higher prices and fewer options for patients. There are many facets that contribute to this problem, and we need to work together and find a bipartisan solutions. Whether we're talking about insurers buying large PBMs, pharmacies, or even medical practice to create huge corporations, insufficient site neutrality policies in Medicare, large nonprofit hospitals buying everything in sight, prohibition on physician-owned hospitals. We hear time and time again from our constituents that our healthcare system is failing patients since current federal incentives make the system less competitive and more expensive. I represent one of the oldest districts in the country with about 250,000 seniors living there. Some of the best competition in healthcare marketplace is found in Medicare Advantage and Medicare Part D, with Part D celebrating, frankly, its 20th anniversary this year. Initially, Republican ideas, these programs have found their ways to keep out-of-pocket costs down for seniors and have robust marketplaces where enrollees can shop for plans that work best for them. On the other end of the spectrum, one of the worst examples of consolidation over the last few years is an increase in somewhat referred to as a vertical integration. This most often occurs when you have insurers, PMBs, and pharmacy merge, creating a huge monopoly which decreases patient access and increases prices. While the FTC allows these mergers to occur, they're in different areas of healthcare. They no less create problems. They result in fewer options for patients and reduced competition. We can all agree that prescription drugs cost too much, but while generics account for 90% of the prescriptions filled each year, the three PBMs control about 80% of the market share. Competition isn't working how it should. Unfortunately, consolidation like this isn't unique to insurers and pharmacies. Large hospital systems are moving into the area where they previously had no footprint, buying up smaller hospitals and independent practices in order to increase their size and stamp out competition. The hospital care accounts for nearly 1/3 of all the healthcare spending, over $1.3 trillion in 2021. This spending will only continue to increase if we don't find ways to create more site neutral and increase competition in areas where one healthcare system buys up or drives out all the others. Actions like these are a disservice to our constituents, and it's time we shine a light on them. We all want to preserve and promote access to high-quality healthcare for all Americans, but Congress has looked the other way too long, and we can't let this continue. I worked with my colleague, Speaker McCarthy, on the Healthy Future Task Force to come up with ideas on how to address affordability and the lack of competition in healthcare. The findings and recommendations we released last summer are just a starting point. We must work together in this committee to find common ground and apply what we've learned to craft bipartisan solutions. Any policies we should aim at should save patients money by paying doctors based on the care they receive rather than what they give, encourage greater competition, not consolidating, and ensure no one can game the system through anti-competitive behavior that harms our constituents. It won't be easy, but our constituents are the ones hurt by the inaction, and we owe it to them to fix the problem. As I said, I'm hopeful that we can find bipartisan solutions to the problems of consolidation in the healthcare market. I look forward to working with my colleagues on both sides of the aisle to right this wrong. Now I'm pleased to recognize the gentleman from Texas, Mr. Doggett, for his opening statement.
Well, thank you very much, Mr. Chairman, for hosting today's hearing. I believe that you have a topic here on which we can get some bipartisan cooperation, consolidation, and anti-competitive activity in the healthcare market. I look forward to working with you to address some of the recommendations that our witnesses are offering. I've always supported a competitive free market as the best way to ensure fair prices and promote innovation. Good old-fashioned American competition has brought us technologies that we rely upon today, and healthy markets mean reasonable prices for a wide range of products and services. When competition is reduced and whittled away, monopolies and oligopolies hike prices, ignore quality, and work to maintain their monopoly power rather than advancing new innovations. Some of our greatest health market failures are occurring in the pharmaceutical space, with 3 pharmacy benefit managers, as you just mentioned, now controlling about 80% of the market, and all 3 consolidated with an insurer and a pharmacy. The PBM market is full of conflicts. Community pharmacists like Mr. Moose, who will testify, like my friend Ray Carbajal in San Antonio, and many others, are all too familiar with the problems posed by consolidation. These community pharmacists are a vital part of our healthcare system, often offering their patients invaluable professional counseling that they're not receiving anywhere else. And just as hospital and provider consolidation is edging out independent providers, PBM and pharmacy consolidation is resulting in independent community pharmacies being dropped from networks or effectively edged out through anti-competitive contracts. I don't believe that there is any single PBM reform that is a panacea, and I think some of those that are recommended will do more harm than good if implemented in isolation without reforms that are directed toward manufacturing pricing. We need guardrails that harness the negotiating power of PBMs while ensuring a fair market. And recognizing that many drug prices are effectively non-negotiable because of pharma monopolies, we need policies that ensure reasonable prices from the moment a drug is launched and timely generic competition to further reduce cost. In the pharmaceutical space, government-sanctioned monopolies through patents have granted manufacturers lengthy periods of market exclusivity and monopoly pricing power. Big Pharma then manipulates our patent system to extend their monopolies and delay competition just as long as they possibly can. By one estimate, about $40 billion in taxpayer dollars were wasted in 2019 alone on drugs for which Big Pharma was able to delay competition. Thanks to this anti-competitive behavior and monopoly prices, 30% of American adults report not picking up prescriptions or skipping doses because they couldn't afford the prescription. Last year, one single pharmaceutical manufacturer made over $100 billion in revenue. Where are those profits going? Well, we like to think they are directed toward new cures, but in fact, pharma pours millions into lobbying this Congress to block even the smallest reform, and after years of denying that there was a drug pricing problem, they've begun almost daily pointing their finger at their favorite boogeyman, pharmacy benefit managers. I can't open a Capitol Hill newspaper without seeing a colorful pharma-funded ad attacking PBMs. And there's a reason for that, because despite their limitations and restrictions, PBMs are the only part of the supply chain that is pushing back on monopoly drug prices. Though I'm certainly not a defender of some PBM anti-competitive behavior, these so-called middlemen are one of the few tools available to contain outrageous manufacturer prices. Since Big Pharma secured a law that began in this committee room to deny Medicare the right to negotiate drug prices, pharmacy benefit managers are among the few that are able to negotiate substantial discounts. Increasing healthcare consolidation combined with flawed system design and policies that sanction monopoly behavior is failing patients across the healthcare system. There's much more to say, Mr. Chairman, but I know we have witnesses to hear, and I look forward to working with you towards some solutions.
Thank you. I appreciate that. I will now introduce our witnesses. Mr. Richmond is a professor at Duke Law School. Mr. Moretti is the Oklahoma Insurance Commissioner. Mr. Moose is a community pharmacist in North Carolina. Mr. Isasi is the Executive Director of Family USA. Dr. Rome is a professor of medicine at Harvard Medical School. The committee has received your written statements and they will be made a part of the formal hearing record. Mr. Richmond, you are recognized. Turn on your mic.
Thank you again, Mr. Chairman and members of the committee. It's a distinct honor to testify before you today about a matter that is extraordinarily important to the nation's long-term fiscal health as well as its physical health. Precisely because the topic is so important, I am delighted to report that some things in healthcare are not complicated. One rudimentary principle of economics applies in healthcare as elsewhere. When there is less competition, prices go up, quality goes down, innovation is stifled. This has been especially true for America's hospitals. The title of today's hearing has the matter exactly right. Why is healthcare unaffordable? It is because of consolidated markets, and especially because of consolidated hospital markets. The cost of healthcare is unsustainable not because we consume too much healthcare, but because we pay too much for the healthcare that we do consume. Prices are the problem. The biggest problem is hospital prices, and hospital prices are high because of hospital monopoly power. It took a long time to convince policymakers, business leaders, and judges that it was bad to allow hospitals to merge. Antitrust enforcement has beefed up in this area, and it has commendably earned some successes. It needs our further support. But competition policy in healthcare needs to go beyond traditional prevention of hospital mergers. My testimony outlines 3 critical policy areas in need of attention. Number 1, anti-competitive conduct by current hospital monopolists. In other words, we need to limit the damage that is now being wreaked by monopolists that we were allowed to form. Number 2, the rise of hospital physician mergers. Markets and patients alike suffer a variety of harms when hospitals acquire nearby physician practices. These acquisitions have been sweeping across the country for approximately the last 10 years. And third, the rise of hospital mega mergers, or so-called cross-market mergers. These are also sweeping across the country, and they do not create benefits for patients, but do create significant harm on markets. I offer 3 general suggestions to improve competition policy in the healthcare sector, and especially to address the problem of hospital monopolies. First, I encourage charging CMS with more responsibilities in advancing competition policies and competition objectives. They have enormous capacity to help in competition policy. Second, private employers, who are the primary purchasers of healthcare in the commercial market, could do much more to improve the efficiency of markets and the welfare of their employees. ERISA offers some productive tools in encouraging these purchasers to be more wise in their purchasing of healthcare and more loyal fiduciaries to their employees. And third, we need to confront a growing trend in which state legislatures are immunizing hospitals from normal antitrust enforcement and thus shielding even the worst conduct from scrutiny. I speak to you as a proud North Carolinian, so it is with enormous dismay that I report that the North Carolina Senate recently approved a bill that would give full antitrust immunity to one of the state's major health systems. This bill would permit all of the monopolistic conduct that this committee and this hearing decries. This problem is not specific to North Carolina, but North Carolina is the most recent and in many ways the most brazen instance of this trend. We cannot make any progress on competition policy if state legislatures block the antitrust laws at square one. Congress can prevent state legislatures from protecting their favorite hospital monopolies, but these actions and these recent developments suggest that we all have much work to do, not just in advancing the right policies, but also convincing policymakers nationwide of the real harms of consolidated hospital markets. Thank you.
Thank you, Mr. Mulready. You are now recognized.
Thank you. Good afternoon, Chairman Buchanan and Ranking Member Doggett, and members of the subcommittee. My name is Glenn Mulready. I currently serve as the 13th elected insurance commissioner from the great state of Oklahoma. I've served in this role for the past 4 years, having just been reelected for another 4 years in November. Previously, I served in the state legislature for 8 years, where I chaired the insurance committee and later served as the majority floor leader. This past year, I chaired the Health Insurance Committee for the National Association of Insurance Commissioners. I've basically been in the insurance business my whole life. This coming October, it will be 40 years since I was first licensed. The 27 years previous to me becoming insurance commissioner were solely focused in the health arena. Like my counterparts in other states, I work to maintain competitive markets for insurance in my state. Competition is strong in Oklahoma. In our individual market, we have 6 insurers currently offering coverage. However, assuring competition for health insurance can be challenging due to the complex interaction of state and federal regulations. ERISA keeps the benefits of self-funded employer plans outside of state jurisdiction. Adding to the challenge is the complicated healthcare delivery system with many sources of coverage, providers of service, and middlemen like PBMs that we've heard about already, some of which fall under our authority at the state insurance regulatory role, and some of which do not. Today's topic is one I've worked on for more than 2 decades in Oklahoma. There are many facets in the healthcare delivery system. The one component that I have lived in during this time is the financing of healthcare. Over my years in the business, we've seen the constant pull between hospitals and healthcare systems and health insurers who continue to try to constrain costs and manage care in order to try to keep premium costs down and affordable to consumers. The consolidation of hospitals and healthcare systems have made this even more difficult. Our rural communities have specifically been hard hit. I'm a strong believer in the competitive free market system. However, the consolidation that has taken place has not helped in this constant struggle. A specific area of great concern is the rising cost of prescription drugs. Over the past 20 years, we've seen this move from an average of mid-teens of health insurance premiums to now 22% where it stands today. In Oklahoma, our legislature has specifically targeted PBMs and trying to reel in some of the market controls and trade practices that have become commonplace in this area. PBMs are companies that handle prescription drug services for health insurance companies, as well as large self-insured employers. They handle things like networks of pharmacies, formularies, processing of prescription drug claims, et cetera. We've been enforcing this legislation since September 1st of 2020. During this time, we've received complaints of over 300,000 violations. We've issued fines of over $3.5 million and have reimbursed back to local pharmacists over $700,000. We find ourselves at the tip of the spear on this nationally hot topic, and in fact, just yesterday, the landmark ERISA case, PCMA versus Mulready, was heard in federal appeals court in the 10th Circuit in Denver. This case involves the issue of state laws pertaining to PBMs and ERISA plans. The lower courts in this case have generally decided that there is not an ERISA preemption for our law. In an earlier case that ended up at the U.S. Supreme Court, a similar decision was rendered in the PCMA versus Rutledge case. The PBM market is controlled by 3 large PBMs, as you've heard. These are very large. We're talking 2 of the 3 are in top Fortune 10 companies. This can lead to a reduction in cost. They also have become vertically integrated, meaning these companies own a health insurance company, they have the PBM, and in some cases, a chain of pharmacies. This can lead to a reduction in cost due to leverage with wholesalers and manufacturers, but also can lead to some strategies to maximize profits, such as spread pricing, preferred formulary placement, in order to gain that profit. In this area, as in much of what I would have to say in a broader conversation, is that transparency is critical. An important aspect of competition among health insurers is in establishing a network of providers. The payment rates and other contract terms that insurers negotiate with the providers who make up their networks goes a long way to determining health insurance premiums and the level of competition for health insurance. Another practice we've seen in our market is higher prices charged by hospitals for care delivered in outpatient departments. A hospital outpatient department that is located off-site might provide the same service as in a physician's office in the same type of clinic, but at a large facility fee because of the hospital affiliation. This raises prices with no benefit to the insured. It also tends to limit competition because it creates a large incentive for hospitals to acquire physician practices so the hospital can start adding facility fees to their bills. And to expedite this, I will say in Oklahoma, we've been working hard to promote competition by protecting consumers' ability to use retail pharmacies when and where they choose. We hope Congress will support us in our efforts to limit anti-competitive practices in healthcare by PBMs and other entities. It can do that by protecting state authority. Thank you for the opportunity to be here today as we work together to protect consumers and ensure access to affordable choices. Thank you.
Thank you, Mr. Esaucy. You are now recognized.
Thank you very much, and thank you for the opportunity to testify today. My name is Frederick Esaucy. I'm the Executive Director of Families USA, a national, nonpartisan voice for healthcare consumers for over 40 years. Simply put, our healthcare system has lost its way. We have incredibly expensive and unaffordable care. We are not delivering on the promise of health our families deserve, and we are creating terrible financial insecurity and debt for families across the nation. Consider, for example, that almost half of all Americans have to forego medical care due to the outrageous cost. For a third, healthcare costs are interfering with the basics like heat or rent. And for over 40% of Americans, that's over 100 million people, they live with the crushing burden of medical debt. And this includes tens of millions with health insurance, who've been paying their premiums every single month and still are being saddled with debt. This financial crisis is occurring despite the fact that we spend 2 or 3 times more than other wealthy nations on health care. That's $13,000 for every woman, man, and child in this country, $13,000. And for all this money, what are we getting? Very often we are getting low-quality care that is hurting our nation. In fact, compared to other wealthy nations, Americans are much more likely to die when they enter the healthcare system when the system should have saved their life. Much more likely. And believe it or not, 250,000 people a year in this country die, not from their illness, but from the medical system itself. 250,000 moms and dads, children, friends, and neighbors, grandparents die each year because the medical system kills them, not their illness. At its core, our nation's healthcare affordability and quality crisis are driven by a fundamental misalignment between the business interest of the healthcare sector and the health and financial security of our nation's families. Americans in many communities have watched for decades as their local hospitals became health systems. Those health systems were then purchased and became part of large healthcare corporations. What most have not realized is how much this has destroyed any real competition in our healthcare sector, allowing hospitals to act as monopolies and abusively increase prices year over year. In the most recent decade, hospitals have increased their prices 4 times faster than our paychecks, 4 times faster. The American people need you to act now. First and foremost, we need the information to hold the healthcare sector accountable. We urge Congress to pass legislation to strengthen the hospital price transparency rule. How can a hospital corporation argue against patients being able to know in advance how much a service will cost us? Second, the committee should address price gouging by site of service. To understand what that looks like, let me tell you about a patient. Her name is Kei Lung Lee. Miss Lee spent decades working as a dry cleaner, and at 72 years old, has very painful arthritis in her hands. Once a year, she goes to the rheumatologist for a steroid injection to relieve the pain. Typically, each round of injections costs about $30. And about 2 years ago, she arrived at her usual appointment, and the rheumatologist had moved upstairs. Miss Lee didn't think much about that. The rest of the appointment went as usual, but she received a bill for $1,394. That's right. Her bill had increased from $30 to $1,400. The clinic that Miss Lee went to had moved from an office-based practice to a hospital-based practice, and as a result, increased their prices by 4,000%. This is crazy, it makes no sense, and is an example of the corporate looting going on in our healthcare system. We urge the committee to implement site-neutral payment policies as recommended by the Medicare Payment Advisory Commission. And finally, we urge the committee to ban anti-competitive practices and clauses in healthcare contracting agreements. You may have all seen the news this morning. It looks like about 2/3 of the healthcare workforce are all subject to these agreements, 2/3. Let me close by saying that these aren't just smart, common sense solutions. They're also wildly popular. The American people want action. Most voters on both sides of the aisle want this by a mile. Thank you again for holding these hearings today and inviting us to testify. I'm happy to take any questions.
Thank you, Mr. Moose. You are now recognized.
Thank you. I greatly appreciate the opportunity to speak with you about why health care is unaffordable. My name is Joe Moose. I'm a pharmacist and co-owner of Moose Pharmacy in 7 locations in North Carolina. My pharmacy was started by my great-grandfather in 1882 in Mount Pleasant and is still there today in the same location where I practice with my brother as 4th-generation pharmacist. I'm a member of the National Community Pharmacy Association. Over the past 140 years of our pharmacy, our community pharmacies in rural North Carolina have been the primary access point for those in need of health care. We're the only pharmacy for miles in many communities. This is now being jeopardized by the pharmacy benefit managers that determine who has access to our pharmacy, what prices patients pay, what reimbursements pharmacies receive, and what medications are on the formulary. This is all being done under the guise of pricing drugs lower. The most expensive patient to the healthcare system is not the patient with diabetes, hypertension, and high cholesterol who takes 10 medications a month. It's that same patient who takes 0 medications a month because the PBM has put up barriers limiting their access to care. What about the senior who is not comfortable driving 15 miles to the big city that has a PBM-owned pharmacy, so that patient must pay cash for full price of their medication at our pharmacy because we're not in network? How much cost savings is there to the patient who does not have transportation and goes without medicine? Is there really a savings if a higher price preferred brand drug by the PBM sends the Medicare patient into the donut hole faster and the patient is now paying out of pocket? Who is recognizing these savings? The PBM, not the patient, not the payer. These are not exceptions like they'll have you believe. These happen daily in our community. As you know, PBMs own drug plans, the pharmacy, the physician's office. They steer patients to utilize their PBM-owned pharmacy. Today, the top 3 PBMs, Caremark owned by CVS, which also owns Aetna, Express Scripts owned by Cigna, and Optum owned by United, control 80% of the market. I hear many patient experiences with PBMs every day where people in my existing customer base have received letters, phone calls, and even gift cards encouraging them to transfer their prescription, making them believe they don't have the option to come to my pharmacy anymore. This happened to a family member of one of my pharmacists just this week. Keep in mind that the clientele that the PBMs are targeting are often seniors who have selected Medicare plans. This type of marketing and coercion can be very confusing and troubling to seniors. Many times they have come to me in great distress. They don't want to leave our pharmacy where they know the pharmacist and the pharmacist knows their healthcare situation, but they feel pressured to change. The PBMs act like a toll booth, collecting fees from local pharmacies, including harmful pharmacy direct and indirect remuneration or DIR fees, for which are getting worse. Pharmacies continue to see take it or leave it Medicare Part D contracts where the reimbursement rates are significantly below our cost to purchase brand name drugs. Pharmacists also see these low reimbursement rates in Medicaid while the PBMs turn around and bill the states a higher rate and keep the excess. This practice is known as spread pricing, and more states are waking up and banning this. The claim of the PBM is that they are saving the patient in the healthcare system millions of dollars. Millions of dollars of what price? I could offer any of you 50% off if you come in my pharmacy today. The question should be 50% off of what price? A price that is made up. If the PBM industry continues to go unchecked and is not transparent in the operation, you run the risk of putting businesses like Moose Pharmacy and thousands of other pharmacies out of business. If these pharmacies that operate in underserved areas are forced to close, you'll be left with a deficit of care for patients, which will ultimately drive up the cost even more of care for those individuals, as well as delay in care, decreased access, and a less competitive marketplace with higher prices. The patients lose and the taxpayers lose. You ask why health care is unaffordable. PBMs act like toll booths on the highway of health care. They collect fees, which they get to make up from who they want based off pricing schemes that they create. Community pharmacies are eager to work with the committee to address the anti-competitive practices in consolidated PBM market that has worsened with vertical integration. Congress must consider legislation to address PBM practices in Medicare and Medicaid, especially as prescription drug prices continue to increase at an alarming rate. I applaud the committee for holding this hearing and looking forward to congressional action to reform PBM practices in a way that will lower drug prices at the pharmacy counter for our patients. Thank you.
Thank you, Dr. Rome. You are now recognized.
Chairman Buchanan, Ranking Member Doggett, members of the subcommittee, my name is Ben Rome. I am a practicing primary care physician and instructor in medicine at Harvard Medical School and a health policy researcher in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital in Boston. My research focuses on the use, regulation, and cost of prescription drugs, and I am honored to be here today to talk with you about how to make medications more affordable to patients. 1 out of every 4 Americans has difficulty affording their prescription drugs. This has serious consequences because effective medications do not work when patients cannot afford them. The main driver of high drug prices in the U.S. is simple. We grant drug makers patents and other government protections that prevent competition during periods of market exclusivity. During this time, we let drug makers freely set and raise prices as high as the market will bear. As a result, we have seen prices for new drugs skyrocket. The average price for a year's supply of a new drug entering the market has soared from $2,000 in 2008 to more than $180,000 in 2021. The most important actions that Congress can take to make prescription drugs more affordable is to address the high prices set by manufacturers. For example, Congress could expand the authority for Medicare to negotiate prices that was included in the Inflation Reduction Act, and Congress should promote policies that encourage timely generic competition, such as preventing manufacturers' abuse of the patent system. Recently, there has been a lot of concern among members of Congress about the role pharmacy benefit managers play in prescription drug prices. Most health insurance plans contract with PBMs to manage prescription drugs. To control costs, PBMs create formularies that steer patients towards less expensive medications, and to do this, they charge patients higher out-of-pocket costs, or they restrict access to high-cost medications. These formulary tools can be frustrating for clinicians and for patients, particularly when they prevent or delay the appropriate use of medications. For policymakers, it can be tempting to enact rules that protect patients by capping out-of-pocket costs or blocking utilization management tools like step therapy. However, PBMs use these formulary tools to negotiate discounts from drug manufacturers. And enacting policies that restrict PBM's ability to manage formularies will impede their ability to negotiate lower prices for some drugs. To avoid this, such policies need to be paired with other policies that directly address the root problem: high prices set by manufacturers. That said, there are several practices with how PBMs conduct business, and Congress should address these. I will discuss 3 today that have clear policy solutions. Lower drug prices, PBMs negotiate rebates that are paid by drug manufacturers after the point of sale. In some cases, PBMs retain some of the rebates as profit. In addition, the out-of-pocket costs for patients using expensive medications are usually based on manufacturer list prices that do not include rebates, even in cases when PBMs have negotiated substantial discounts. Congress should fix this by requiring PBMs to pass 100% of the rebates they negotiate onto plan sponsors, and should require the plan sponsors to use these rebates to lower premiums and offer more generous coverage. In addition, Congress should prohibit PBMs and insurers from tying patient out-of-pocket costs to list prices that exclude rebates. Second, PBMs sometimes contract with health plans using a strategy called spread pricing, in which the PBM charges insurance plans more than they pay pharmacies, allowing them to pocket the difference. This misaligns financial incentives, allowing PBMs to profit from higher prices. Congress should prevent PBMs from engaging in spread pricing. Finally, each of the major PBMs now owns or affiliates with a mail order and specialty pharmacy. Increasingly, PBMs are steering patients to purchase medications at their own pharmacies, and this is a serious conflict of interest because PBMs are negotiating prices that are paid to their own pharmacy. To address this, Congress should act the Government Accountability Office to investigate the impact of vertical consolidation between PBMs and pharmacies. And additionally, PBMs should be required to disclose markups when they fill medications at their own pharmacy. Despite these problems with PBMs, it is important to remember that the primary driver of prescription drug prices in the U.S. is high brand-name drug prices set by manufacturers. Drug companies love to point fingers at PBMs, and there are some problems with how PBMs conduct business. But to really make medications more affordable to patients, Congress needs to address the skyrocketing prices set by drug companies. Thank you for the invitation. I look forward to your questions.
I want to thank you for your testimony. I want to thank all our witnesses for being here, taking time out of your schedule. This makes a huge difference to this subcommittee. Well, I'd like to proceed now to questions and answer session, and I will begin. Mr. Mulready, you took on the PBMs in Oklahoma and won, paving the way for states to regulate benefits design. Given your success, what would you recommend? What would be a couple of things to fix the broken system of incentives that BPMs create in order to drive down the cost in terms of our constituents and pay for prescriptions?
Thank you for the question. You know, the Oklahoma legislation, I didn't get into that in my opening statement, but attacked things like transaction fees, outlawed the ability of PBMs to just charge transaction fees, very black and white thing that could be addressed. Also did a lot in regards to steerage, steering to, as we've heard from the panel here, much of the panel, steering towards owned pharmacies and limiting that choice. Our law says that you're not allowed to steer, that any in-network pharmacy and any pharmacy can be in-network, that they could be utilized within that. If you're going to mention a pharmacy by name, you have to mention all pharmacies. So those are some of the things that were addressed in the Oklahoma law.
Thank you. Mr. Moose, according to credible story about your family being in business and that, but according to some estimates, there are just 1,900 independent pharmacies in the U.S., but they do employ 240,000 people. If you were to change a couple of things as it relates to BPMs that adversely affect your business and the industry, what would they be? Could you expand or expound a little bit on what you said a little bit earlier?
Yeah, absolutely. Thank you for the question. Transparency, there's no transparency. We have a mechanism for pricing drugs, which is NADAC. So when they have their price, it's a made-up price. And then they also have the ability to give us something called a maximum allowable cost on a drug, where they throw out all the rules and they make up their own price for that. So to make pricing based off NADAC, a published, transparent pricing model, and then a dispensing fee on top of that would be a great start for it.
Well, thank you. I now recognize the ranking member, Mr. Doggett, for any questions he might have.
Thank you, Mr. Chairman, and thanks to the testimony all of you provided. My concern, and I'll direct this to Dr. Rome, is I want to address the problems that Mr. Moose so effectively described without wrecking the ability of the only participant in this process to push back against big pharma manufacturing cost or prices. You've mentioned several specifics, and I'm pleased you have been so specific. I think on one of them, getting the Governmental Accountability Office to investigate the impact of vertical integration ought to be something we can do as a bipartisan request, even without legislation, and I think we should do that. On the other ones that you mentioned, the 3 or 4 specifics that you have, of which I suppose the most significant is requiring that 100% of rebates be passed on. If we were to do all of that, as you recommend, without doing anything about the anti-competitive practices of manufacturers, what would the impact be on the system? And is that what you're recommending, or is there some portion of these you're recommending? How do we avoid the system becoming even more imbalanced than it is today?
Thank you for the question. Mr. Doggett. I do think that we, Congress and this committee should pay attention to PBMs and think about some reforms that really put the patient and the consumer at the center of the legislation. And that includes avoiding gaming and avoiding the made-up prices, essentially the list, the prices sort of being passed on to patients. Now, those list prices are set by drug manufacturers. And to your point, PBMs are negotiating lower prices for some drugs. Now, for brand name drugs, there is no direct competition. Drug manufacturers do as much as they can to extend the period during which there's no competition. In some cases, PBMs have ability to leverage competition between different brand name drugs. And if you do impose restrictions on their ability to do that, such as sort of just restricting their ability to use tools to do that, you do risk prices going up. But ultimately, they're negotiating off the price set by the manufacturers, so you should be tackling both problems at the same time. So the Inflation Reduction Act does both. It addresses high prices by manufacturers, and it redesigns Medicare Part D to make it more effective and a more generous coverage for patients. So that's the type of policy that when you combine those things together can be very powerful.
Well, the problem we have is that even what I view as extremely modest and narrow reforms on Medicare price negotiation that were adopted last year, even those are under attack. The ability of this Congress to break free of the stranglehold of Big Pharma is just not there. We're not going to expand that negotiating authority. And my concern is how much of this PBM reform we can accept and adopt, hopefully on a bipartisan basis, without leading to even higher drug prices than we have today.
Yeah, I mean, I think that some of the practices would benefit from a lot of transparency. So if there's one thing that the committee can do, I agree with some other recommendations here on the panel. As a researcher and for people who purchase healthcare, we just need more transparency in the prices. The rebates that are negotiated by PBMs are completely confidential. Both the PBMs and the manufacturers seem to argue in favor of the confidentiality. It's not clear to me that making those confidential will necessarily have a major effect on prices, and I don't know a lot of research that shows that. So just shining some light on the prices that are actually being paid, making it clear where the problems are in the PBM business model would be extraordinarily helpful as a first step as you consider some of these proposals.
We've talked about these three vertically integrated companies that have 80% of the market. Is there much competition between the three of them?
Sure. I mean, I think that the answer is yes, that there's competition between the PBMs, right? They are very consolidated, but there still are three of them. So inherently, consolidation among the PBMs does not necessarily by itself lead to higher prices, right? They are serving as a effort to push back on higher prices by the drug makers. The monopolies by the drug makers are the thing that are keeping prices high. So the consolidation does have other concerns in terms of how they practice their business. So I would look at those in terms of how do we make sure we regulate, again, with kind of put guardrails in place, as you so nicely said, so that they can negotiate, they can do their job, but they can do it without harming patients, that they can't charge patients more than the cost of the drug. In the case of generics, that they can't charge patients based on a price that they aren't paying much attention to, that they're allowing the manufacturer to go up unregulated. Those sort of practices need to be addressed.
Thank you, Dr. Rum, and thanks to all of you.
I now recognize Mr. Smith, Nebraska.
Thank you, Mr. Chairman. Thank you to our witnesses for sharing your perspective. We're building off of yesterday's hearing on price transparency, obviously, and we examined, I think, that in an effective way. We know that healthcare consumers can't plan for health expenditures or even compare prices if they don't have access to accurate cost information. Although price transparency can empower consumers who only have limited choices of plans or providers. We know that most communities only have one hospital and a limited number of providers. Over-consolidation can put other areas, even those with more providers, in the same situation. We must find ways to ensure competition remains alive and well, while also expanding options in communities. Mr. Richmond, when it comes to over-consolidation and the growth of large health systems, would you say there's a geographic a pattern, urban, suburban, rural areas? Is it more common in certain regions of the country as well?
I think the best answer is that most hospital markets throughout the nation are highly consolidated. And both urban and rural areas are homes to hospital monopolies. I don't think this is a distinctly urban or rural problem.
Okay, thank you. Now, to combat over-consolidation and create more consumer options, I will say we need policies to foster diverse local, regional, and national competition, obviously reflecting on your concerns, Mr. Richmond. I believe that this includes Medicare flexibilities, which give beneficiaries more provider options. For example, legislation I recently introduced, the Equitable Community Access to Pharmacist Services Act, or ECAPS, would allow for Medicare to pay a pharmacist for the testing, treatment, or vaccination for common respiratory diseases. I believe that increasing the provider pool gives local pharmacists more ways to benefit their communities and can be done while respecting state-level scope of practice rules as well. Actually, I think it's exciting to see the manifestation of pharmacists bringing more value, more opportunities, more information and insight for patients, especially at the local level. Increasing number of services that they can provide throws what many would say a lifeline to many pharmacies which operate in this increasingly challenging environment. Mr. Moose, overconsolidation and a lack of negotiating leverage have been cited as a contributor to pharmacy closures, which itself leads to further consolidation and decreased consumer options. Can you tell us how a pharmacy closure actually impacts a community, and especially a rural community?
Yes, absolutely. When you look at a lot of these communities out there, especially the rural communities, that is the health center of that community. That was the entity that stayed open during COVID. That was the entity that immunized that entire community during COVID, that also tested those individuals and got treatment during that time. That's the same entity out there that is taking care of that community, knows the social determinants of health of those individuals, knows other community resources that they could go to. You can't have that through mail order. You can't have that through technology or call centers to know that the church down the road offers Meals on Wheels or maybe some copay assistance. So when that pharmacy dries up and leaves that community, those individuals in that community suffer. And there's a direct relation with the increase of healthcare costs when that resource is not in the community. They no longer have access to the same quality of healthcare that they had. So they have to go farther, seek more expensive care, and that is if they do that. In a lot of cases, they don't do that because they don't have the ability. So you're actually talking about increasing the total healthcare spend considerably. If you look at what community-based pharmacies do, is they fill very cheap generic drugs. You're looking at less than 1% of the $3.6 trillion budget to keep that pharmacy in business.
Is it fair to speculate that you would receive a call from a patient who received their prescriptions through another mail order perhaps, but they would expect you to answer questions as well?
Every single day, we pick up the slack of what the mail order, the void it leaves. The person who didn't receive their prescription in the mail, that we have to try to fill. We had an individual that had an antibiotic just last week that had an antibiotic that was 2 doses 3 days apart. They got the first one filled, came in 3 days later to get the second dose filled, and the insurance rejected it, saying it needed a prior authorization. When we spent 2 hours to get that prior authorization, and the reason they didn't get it is because they thought it was supposed to be coming in the mail. When they didn't receive it in the mail, then we had to spend 2 hours to get that prior authorization for that individual. So you see that daily.
Yeah, thank you very much. My time has expired.
I now recognize the gentleman, Mr. Thompson from California.
Thank you, Mr. Chairman. Thank you for having this hearing, and thank you to all of the witnesses. First, I'd like to ask Dr. Rome a question. How is it that prescription drugs through the VA are so affordable vis-a-vis the private sector?
Sure. The prices at the VA are a lot lower than they are in Medicare or in the private sector because the VA is a single healthcare system that negotiates prices and sets a clear formulary. They're basically able to have a very strong leverage to negotiate low prices on a smaller number of drugs for their patient population.
It's substantially different. And I use the VA to, for my cholesterol drug. And it's hundreds of dollars versus a few dollars. And it seems to me that we could be moving more in that direction and negotiating, using our tremendous buying power to negotiate these prices.
Yes, absolutely. Medicare has tremendous buying power. We're going to see the power that has on 10 drugs that will be announced in September. My guess is, we've done simulation exercises of that law, and we expect that Medicare could reduce its drug spending within the first 3 years by 5%. That's backed up by the CBO estimates. So if you do negotiate prices, you can make substantially lower prices for patients.
Thank you. I hope we look to the VA for a model in this regard. For the other witnesses, I'm having trouble trying to reconcile the issue of consolidation as it pertains to keeping the doors open in some of the hospitals, facilities that we have, and providing access to closing up the facility. And it seems right now it's a real struggle for a lot of folks, and I don't think just in my district. I'm seeing it in the suburban parts of my district and in the rural parts of my district. Folks are really struggling. And I think there's a difference in trying to consolidate to be able to provide services and to consolidate in order to maximize profits. And so in the instances when a facility has to consolidate in order to continue to provide access, what should we be doing, those of us on this dais, to make sure that they're doing it for the right reasons and that that people in our community aren't going to lose access? And we just had one, it's in a county that I share with another member, but a hospital consolidated and promised to keep their birthing center open, something that was really important to the community, for 5 years. And within the first year, they temporarily closed it because they can't find a doctor or something. And their response to the community is, well, you can just drive to this next city for birthing practices. And in traffic, it's an hour's drive away. It doesn't work. So I'd like to get some direction from you expert witnesses on what we can do to prevent that type of behavior.
Yeah, Congressman, your story is very, very common. I can't think of a single proposed hospital merger where lots of promises for both efficiencies and access have been made. I can't think of any hospital merger where prices have not significantly increased afterwards. And there's a lot of empirical evidence to this as well. Whatever the intentions are, when hospitals merge, prices go up. Doesn't matter if the hospital is for-profit or nonprofit. Doesn't matter if they're large or small or community-based. And the only thing I could say as a matter of prospective policy would simply be to recognize, especially when hospitals are delivering lots of promised benefits, to know that there almost is not a counterexample of any hospital post-merger not increasing prices, whatever the market can bear. Now, I will say one additional thing. I think that the policy objective is not to keep the hospital door open, but to keep a provider's door open.
Correct.
Mr. Moose gave a terrific example of how he, as a pharmacist, provided and continues to provide a variety of different healthcare services. The same can be said for nurse practitioners, for physician groups. And by and large, especially in rural areas, hospitals give the most expensive care and very often the lowest quality care. And to the degree that we really think about patients in rural communities and think about how we can maintain access to care, we have to think beyond access to hospital care. We have to think about more effective community and less expensive kinds of care.
Thank you very much.
I now recognize Mr. Kelly, Pennsylvania.
Thank you, Mr. Chairman. Thank you all for being here. So I have been in the retail business all my life, and I know I infuriate some people by comparing selling cars and trucks and servicing cars and trucks as to what we face in the medical field and prescription field. So I did bring a window sticker. And I don't give a darn where you price up this Traverse. This one happens to be one on our showroom floor. If I were to go to Anchorage, Alaska, it would be the same window sticker. If I went to Miami, Florida, it would be the same window sticker. And Dr. Murphy and I talk about it all the time. It's not the same market. And I get that, but it is the same market for Chevrolet products. It is the same market for Ford products. It is the same market for Chrysler products and Toyota and every one of them. Whatever it is they have to offer, it's the same price no matter where you go to get it. Now, this was a huge problem in the United States, and this is where it comes in. I don't know how we regulate what you all do, honest to God. I mean, but in 1953, Senator Mike Maroney came up with an idea. You couldn't know what the price of any car was because there was no window sticker. So depending on where it is that you got access to it, it could be anything. And there could be thousands of dollars apart. So I'm thinking with these PBMs, now when I bid on vehicles for the local cable TV, they're going to buy 50 trucks. I call Chevrolet and I say, I'm going to need bid assistance on this because they're buying 50. And they'll say, you know what? Discount it another $2,000. We'll reduce your price $2,000 because you're selling them 50 at a time. I don't know how PBMs do it, but I think it was, Mr. Moose, you said it. It doesn't matter what the discount is, it's where did you start? How much did you inflate the list price to give you a bigger discount? I mean, look at any newspaper on any Sunday, and you'll find jewelers that say, we're going to take 40% off our already 40% off price. And you say, God, I'm getting 80% off. No, that's not what they said. They said they would give you 40% off the already 40%, and you have no idea what the ring cost. But depending where you are in life, and if you're in love for the first time, it doesn't matter what the cost is. You're going to pay whatever it is. So, how in the world would we begin to come up with some type of normalcy when it comes to purchasing drugs? Now, in the parts department, we have genuine equipment price on parts, which is OEMs, right? Then we also have generic parts, which are oftentimes made by the same company, but put a different sticker on it, and they're considerably less. So I look at the marketplace, and usually the marketplace is what decides on where people will actually buy at whatever price. What can you help us with that any way the government, which I think is the worst run business in the country right now, we're $32 trillion in the red and nobody's caring, but what would you do? What, if you were where we are, what is the something to fix what the problem is? Because you can't fix something with nothing, and we have these conversations, we don't get any conclusions. You guys do it every single day. What would you suggest?
I would say there's two very clear solutions to this, right? And let's just start with your opening premise.
Dr. Murphy says in 10 words or less, but I have already violated that rule, but please go ahead.
So the first thing to say is, it's very important to remind ourselves that PBMs are in fact negotiating a better price for the drugs that are already outrageously priced. So that's a very important function. But when we talk about transparency, I think what a lot of people don't realize is, say a PBM is doing that for a large employer who's providing health insurance for their employees, the large employer is not getting information from the PBM about all the money flow. The large employer does not know, what did you actually pay for this drug? What was the rebate that you got? All of those things. So this transparency is really powerful. The PBM must be required to allow their client, in this case the large employer, to know the money flows that occurred and what did they actually save the employer. I'd say that's the first thing. The second thing is, and this is where you see these terrible examples where people are paying cost sharing that doesn't make any sense. PBMs should not be able to negotiate a price and then use a different price, the list price, for cost sharing requirements for consumers. If you're only paying $5 for a drug, you cannot put a $50 copay on that drug. And those are two very simple, straightforward solutions.
Before you go any further, Mr. Moose, somebody just slipped you a note. Is this about this issue?
Yes.
Okay, please. Listen, you're like, I'm a small retailer.
So my answer to it was like my statement earlier. It's NADAC. We have a price that is a transparent price that everybody knows. NADAC plus your dispensing fee. So that gets the pricing part, that gets the sticker in the window. Now, how do you negotiate the price on it? It's transparency. Before PBMs were around, your physician wrote the prescription, handed it to the patient. The patient went in there and the pharmacist told them how much it was going to cost. They paid for it out of their pocket or charged it, kept their receipt turned it in, and the insurance paid them whatever their relationship was, 80% of that. If, like my colleague said, the drug comes out and it's $100,000, nobody's buying that. The only reason somebody buys a $100,000 drug is because they don't know what they're buying. They don't know the cost of what they're buying on it. So if it's transparent all the way through, here's the cost of it, then people's eyes will get open. People will wake up to what that pricing actually is. And is there a $100,000 value to that? Or is there a $29 drug that will do just as good?
Okay, so the insulin in this pen that I take was developed by the University of Toronto, I believe, in 1933 or 1934, and the people who developed this thought it was so valuable to human beings that they sold the patent for $1. Quite a big price increase, but I have silver scripts, so I get it for a lot less money, but I take it 4 times a day. So this is an incredibly complicated issue. It's not the same as buying a car or truck. It's not the same about buying brake pads or anything else, but it is something we need to look at because it is off the charts and it makes no sense to most Americans. Thanks for staying alive in a really tough business.
Thank you.
I now recognize Mr. Blumenauer, Oregon.
Thank you, Mr. Chairman. I'm listening to Mr. Kelly. I think at times trying to purchase an automobile is every bit as complex.
You've got to come to the right dealer.
I would like to acknowledge that there seems to be a great deal of agreement about problems, and there seems to be some assessment of solutions. I'm mystified that it is hard as it has been for us being able to move forward. Your point, Mr. Moose, about nobody pays $100,000 for some sort of pharmaceutical product. They do if somebody else pays for it. And what we're seeing is there's an effort to try and stick the federal government with these extraordinary price increases that we're not going to be able to sustain. We've talked a little bit before this committee about the trajectory we're on in terms of healthcare costs. And this is one that I'm absolutely convinced that a little competition and common sense would help us move forward. And I really appreciate your clarity from your perspective about what we should do. I am interested in a couple of the other federal players here. Dr. Rome, Mr. Reichman, you want to talk for a moment about the role that CMS could play to cut through this challenge and take a little bit of the burden off Congress?
Yeah, thanks for the question, Congressman. We see in a number of other policy areas how different agencies are assisting the Department of Justice and the Federal Trade Commission in competition areas. The Department of Transportation, for example, helps with airline mergers and other competition policies in transport. And we don't see that with CMS, but certainly CMS has the capacity to do that. They have an extraordinary amount of data. They know very well patient flows. They know very well the delivery system, the infrastructure of the delivery system. So not only would they be able to assess what happens after certain transactions, the anti-competitive effects of certain things that, for the most part, the Federal Trade Commission is required to guess on, but they also would be able to identify which markets create better value, which areas of the country create better value and which don't. So simply from a purely analytical perspective, CMS could offer a lot of insight and policy guidance. Of course, CMS also controls the spigot for a lot of dollars, and it could be more forceful in that sense as well.
Do you want to talk about the control of the spigot, Dr. Rome?
Well, I mean, to the degree that CMS, like anybody else, would be able to identify...
Directing a question to Dr. Rome.
Oh, I apologize.
Sure. Thanks for the question. I mean, I do think that CMS and on the prescription drug side, CMS has been sort of hand-tied for the last 2 decades. We talked about it's the 2-decade anniversary of Medicare Part D. So for Medicare Part D, it's a privatized program. So essentially, the market was broken up, and they're all trying to compete against, to negotiate with the same manufacturers, and the manufacturers have a monopoly. So we've finally broken through that, and CMS is going to have some ability to negotiate drug prices. If they are able to do that successfully, if CMS is able to negotiate prices successfully, it takes pressure off the PBMs. The PBMs no longer have to do that work, and it frees you all up to make sure that they're doing their job and making sure to drive patients towards effective, safe medications that are high value and are going to help their care. That's the job they should be doing. They are right now focusing on doing the work of negotiating prices when they are really sometimes not able to do so. For cancer drugs, they are almost unable to negotiate prices. The average rebates that they get from Medicare plans are able to negotiate for cancer drugs is 2%. So there are situations where they're just not able to negotiate, period. And so, we do need to provide some more ability for them to do that.
And do you want to make a comment about the Federal Trade Commission's role in this?
Sure, absolutely. I think on the brand name drug side, brand name drug manufacturers will do as many things as they can to extend their monopolies as long as possible. We see this time and time again. We've studied drug after drug where we've seen this case. There was a multiple sclerosis drug, glatiramar, where the company essentially changed the product from a once-a-day injection to a 3 times a week injection. They were able to relaunch the product and charge Americans $4 to $6 billion extra by essentially delaying competition on the product. By getting an extra patent. The patent was struck down, but it took time. So we need prospectively to review these things. The Federal Trade Commission you need to work with the Federal Trade Commission to make sure we're avoiding those sort of anti-competitive behaviors.
Thank you. Thank you, Mr. Chairman.
I now recognize Dr. Murphy, North Carolina.
Thank you, Mr. Chairman. First, I'd like to ask unanimous consent to enter into the record a statement from a pharmacist, fellow member, GOP Doctors Caucus, Congressman from Georgia, Dr. Buddy Carter. It's about PBMs. Oh, well, he did it too, so take my time back from him. Go ahead. So, thank you, guys. This is obviously an immensely complicated issue. May I have 30 minutes? Just kidding there, sir. Mr. Richmond, let me just ask you, the things going on in North Carolina right now, it seems to me that across every nation now, it is, hey, who is the next person can we acquire or pull something together? The only time I actually ever see that is being appropriate, I live in East North Carolina. We have a lot of rural hospitals. And by the way, they charge more because their payer mix stinks because Medicare, Medicaid, and no insurance doesn't pay anything. And those people are much sicker than the average urban population. 27. But if you look in Charlotte, you look in Greensboro, there are these massive collusions with these massive hospitals. And you're right, you mark up the prices as soon as you walk in. And one of the problems I've seen, private equity should never have been allowed in medicine, but that's a whole different issue. More physicians become employed, the prices go up. I have my office a mile from a hospital, but if I have a CAT scan where it's $600 in my office, it's $3,000 in the hospital. We need to fix that, absolutely. So let me just ask you, why is the consolidation other than to raise prices these days? Can you give me an idea? Microphone, please.
I keep getting that wrong. Congressman, I don't think the data has suggested any reason other than to gain leverage over private payers.
And what it's doing, it's creating these massive monopolies where people really don't have a choice. I'm in a rural part of North Carolina. I don't have a choice. I have a great hospital, worked there for 30 plus years. We own in our system like 9 other hospitals, which would not exist if we didn't make a profit at ours and keep those other rural hospitals alive. But the fact that other institutions are doing this worldwide, United States-wide, look in Houston, some of these other things, is an absolute ridiculousness for our country.
There's one thing that you said that I think really is worth highlighting. I do think that the consolidation phase, which of course has been fueled by private equity, really is creating a crisis for the medical profession. Physicians, really since the founding of the nation, have been independent, and we've relied heavily on that physician independence. And now, very, very recently, 3/4 of physicians are now employed.
Yeah.
And that's something that I think the healthcare sector hasn't fully absorbed yet, and it's going to have some very significant long-term consequences.
I spent many a night on Friday night looking for paper clips to figure out how I was going to pay the staff next week, but that was the most efficient and best care rather than being an employed physician and by having a huge barrier between you and the patient. Let me just speak to Dr. Rome, one of my colleagues. And by the way, Mr. Moose, I feel sorry for you. I think PBMs have screwed the independent pharmacists in this country. I think it's wrong what they've done. I know a lot of guys in our district that have fallen apart. Dr. Rome, you have a much nicer view of PBMs than I do. I agree our pharmaceutical companies have taken a great amount of profit, but for every 10 drugs they put out, one of them works. They've got to recoup some of that loss somewhere. I think the IRA went too far. We've had at least 50 lines of drugs that have been taken off. So if when an ALS patient is looking for a cure, good luck, because you're not going to have that on the line. So let me ask you, the PBMs negotiate, they pull money from the pharmaceutical companies, those don't get passed on to patient. Tell me what a coupon aggregator is and why that's good or bad. Because that's another level the PBMs use to gather money.
So all of this is a game back and forth between the PBMs and the drug manufacturers, and patients are stuck in the middle between this negotiation match and are harmed by this negotiation. So the drug companies set high prices, the PBMs negotiate rebates. The PBMs do so by trying to charge higher out-of-pocket costs to patients for expensive medicines. Then the drug companies come back with coupons, the coupons that they give to patients to offset those out-of-pocket costs, and then the PBMs, in response to that, try to not count that amount of money.
It's a game. It's an absolute shell game that's happening. Personally, Mark Cuban came to visit us at the Doctors Caucus the other day. He just put the PBMs to the side. He's going straight to the pharmaceutical companies. I think that's what we're going to have to do. The PBMs were started out with a great idea, but they've absolutely extorted the American public in doing so with their actions. Thank you, Mr. Chairman. I'll yield back.
I now recognize Mr. Higgins, New York.
Thank you, Mr. Chairman. So CVS Health, Cigna, United Healthcare Group account for 80% of the total claims in 2021 for prescription drug benefits through their pharmacy benefit managers. CVS Health, the salary of the president and CEO is $21 million, 7% of which is salary. The rest is stock options and other incentives. Cigna president and CEO has a salary of $1.5 million and $12.6 million in stock awards. United Healthcare Group CEO had a total salary of $20.8 million, $12 million of which were stocks. And I was just kind of curious as to why stock options in any company, the stock option compensation is an incentive to max out on profits, which, makes sense, by cutting costs and competition. The three of these companies account for 80% of the total claims for prescription drug benefits, would seem to me that they're behaving like monopolies. The Federal Trade Commission is supposed to take action to stop and prevent unfair business practices that reduce competition and lead to higher prices. Mr. Moose, I presume that your family of pharmacies is not associated with any of the three companies that I had mentioned. How does this sit with you?
Yeah, actually, we are. We're slave labor at all three. I mean, those numbers aren't anything that we can even comprehend in it. And so when you have companies like that and that vertical integration that gets to make up their own rules, all we're asking for in business is a level playing field. We don't let the Yankees use aluminum bats. Everybody gets to use a wooden bat. And that's what we're asking for in the pharmacy field. If you're a community-based pharmacy, you have a level of playing field.
Well, three entities, as I previously mentioned, accounting for 80% of the total claims. That doesn't seem to be a level playing field.
No.
Dr. Rome?
Yeah, no, I mean, I agree with what you're saying. I think that, the PBM industry needs, just like every industry where there's a lot of money being made in healthcare, needs to be regulated to make sure that, That consolidation is benefiting patients and not harming them by reducing their choices of where to pick up their medicines. I'm a primary care physician. I see this all the time, that my patients are struggling to figure out where to fill their medicines. Patients should not have to shop around for medicines. That's what the PBMs are supposed to be doing. They're supposed to be doing the work of negotiating prices on behalf of the consumer, right? So we just have to make the PBMs work for patients. We have to make sure that they're able to do their job, but that requires us to have prices that are reasonable, for them to start with.
Okay, speaking about negotiating prices to benefit the consumer, the Inflation Reduction Act includes a provision to allow the federal government to negotiate drug prices under the Medicare program. What will the benefit of that be?
The benefit's likely to be enormous. It's a very limited set of drugs that are going to be negotiated. It's up to 20 drugs per year, and it's just the highest spending drugs. But even in the first few years, we expect the CBO, and we've done a similar study, expect that this will lead to massive savings within the Medicare program by lowering costs. Again, just to be clear, there is competition in the pharmaceutical industry for generics. Right. There is no competition for brand name drugs. For 12 to 17 years.
The Veterans Administration negotiates drug prices. What is a reasonable expectation relative to the savings that will result directly from using the leverage that they have with drug companies?
I mean, the VA prices are about half of those in Medicare.
Half.
Yeah.
So
So I mean,
50%.
so I think that there's a lot to be negotiated. I think that we want the pharmaceutical industry to make money. We want them to. We want everyone in the healthcare space to make enough money to incentivize them to do their job. We just want to make sure that patients can afford the what we get out of that.
Great. Just a final thought, Mr. Chairman. I just, keep in mind that, a lot of drug development, as you know, is a result of a public-private partnership. And the federal government typically will fund the early basic research that leads to eventual drug development. But it's the federal government, the public side, that really expends the costs at very little or no compensation. It's the drug companies that come in the latter stages of drug development that are also the most profitable. With that, I'll yield back.
I now recognize Dr. Winstrup, Ohio.
Thank you, Mr. Chairman, and thank you all for being here. As Dr. Murphy said, can I have a half hour or an hour, or maybe we could sit here for a week, because we really should be doing that in my mind. But I'm just concerned about so many things as practicing physician, private medicine for 27 years. How things have changed. My first year in practice, if someone was just there for an office visit, no procedure, nothing surgical, nothing at the hospital, just an office visit, I gave them their bill and they paid it. And they submitted it to their insurance company. And nobody was complaining. Nobody thought that was a problem. And I was a solo practice at first, and then in a large group of 26 doctors. Solo practice, I had 2 employees when I started, but it just kept growing. It just kept growing. And it's this institutional creep from government, from insurance company demands. It's all these things. And they don't have too much to do with the patient outcomes, to be honest with you. I never really cared what Washington thought about how I was practicing, but I did care about how my patients thought I was practicing and the results that I was getting and my referring doctors. I didn't need Washington. I didn't need to check boxes for Washington. And recently, Doctors Caucus, bipartisan, we meet with the Surgeon General. And he wanted to meet with us. You know what he wanted to talk about? Physician burnout. Understandably. And we've got nurse shortage, we got physician burnout. Why are we burned out? Because everybody else knows how to treat your patients and interferes between the doctor-patient relationship. And then you have these consolidations, and the doctor's just a go-between, really. I mean, I'm gonna ask Dr. Rome. You see a patient, you examine them, you work them up, you do labs, you do x-rays, whatever else it takes, CAT scan, whatever. You've had hands-on, you look them in the eye, you sit down and discuss their problem with them, and you make a plan with them. And then somebody who's never seen the patient, you have to get on the phone with, may not even be in your specialty, and go through. And I've been on there and I say, you're looking at a screen, aren't you? To me, I want to ask you, do you think it's medical malpractice for people to be treating patients they've never seen?
So thanks for the question. I agree with your sentiments. I'm one of the 75% of doctors who's employed by a hospital. I think that, from the case of prescription drugs, when I prescribe a medicine, I obviously think that patient needs that medicine. If there's a system solution to make sure the patient has a more affordable version of that medicine, I would like that to be the case. But, I do think that, this is where the temptation comes in. The temptation is, just allow sort of physicians to prescribe whatever they want. In most cases, that is going to be the appropriate thing. We do need system solutions.
No, I don't believe that in doctors. I don't think people go through that much schooling and training to not do what's best for their patients. And I was never bothered if the pharmacist called and said, hey, you prescribed X, but Y's on their formulary, and you say, well, they're similar, and this patient, it doesn't matter. That's cool. But not fail first. Not have to do something you don't think is right. And that's why we have a bipartisan bill, Safe Step Act, that we're trying to get through, to cut through that so that you can actually treat your patients. And you know if a patient has to wait to get their medication because you're going through all this hassle, administrative hassle, and it delays their care, that is not good for them. And that's what's happening. And then that usually drives up cost. And so these are problems that patients face. But the interference to the doctor-patient relationship, now really, you think there's more entrepreneurship. There's actually less entrepreneurship for physicians as they come out of residency. They're thinking who they're going to go work for. They don't think about, I'm going to go out to my rural town and hang up my shingle. Why? Because it's almost impossible. And that's the system that we have in place. So I've experienced the burden of working through the red tape, drug plan, or just even ordering an MRI. And somebody who has no idea about my specialty is telling me I can't get it. Well, I asked for their license number, and I asked for the patient to be able to see them. But this is what we've gone through. So how can this practice be improved to ensure doctors don't burn out from paperwork and patients don't suffer worse outcomes waiting for the medication that they need? And I'll have any one of you who wants to answer that question.
I mean, I will say that we spend about $1 out of every $4 in administrative overhead costs. And to the degree that we can focus our attentions to simply reduce those totally without value expenditures, I think that's really valuable. And there might be some solutions there. I have some research that I'd be happy to share with the committee.
I think the other solution that's is very important to discuss is when you talk to docs who are tired of the system, the fee-for-service grind on volume, and a never-ending, referral wagon train they're on. And part of the effort is also thinking about how do we redesign the economic incentives in healthcare so that a patient goes to a doctor and the doctor is getting paid to do the best thing possible for that patient. And a lot of the new approaches of trying to change the payment incentives, trying to new global payments, risk-based payments, that's about saying, let the doctor, let her do what she's learned to do, and don't put economic incentives in front of her that are in direct conflict with the patient's interests and the interests of the country.
And reward prevention, if I do say so.
Yes.
But my time is up, and thank you all very much. I yield back.
I now recognize Ms. Sewell, Alabama.
Thank you, Mr. Chairman. I want to thank our witnesses for their testimony today. Prescription drugs continue to increase in this country. Drug costs grew almost $380 million in 2021. Let me say that again. Drug costs grew to almost $380 billion in 1 year, according to the National Health Expenditure data. High drug prices continue to create barriers. Health benefit prescription drugs were created to provide access and health care to patients. We have all heard the stories of Americans of all ages who continue to encounter barriers to life-saving drugs, and yet drug prices continue to climb, with Americans paying almost 3 times as much as for the same drug as other countries, 3 times as much. It's evident that we need reform. The historic Inflation Reduction Act for the first time allows Medicare to negotiate prices. The Congressional Budget Office has stated that similar policies are responsible for increased use of prescription drugs, which led to reduced hospital and physician costs. And as you said, Dr. Rome, the Inflation Reduction Act will have a huge impact and benefit to patients. Simply put, Medicare's ability to negotiate drug prices will increase access to affordable prescription drugs, which is a key to fighting chronic illness. At the heart of accessible and affordable drug prescriptions, Mr. Moose, are independent pharmacies. These pharmacies are key to ensuring that citizens in rural and underserved communities can access those life-saving drugs. I represent a district that includes both urban and rural. The similarity is they're all underserved and vulnerable communities. So I'm particularly supportive of independent pharmacies. It is my hope to see independent pharmacies continue to provide those critical clinical services like vaccinations that was so vital to the folks that I represent during COVID. Mr. Moose, as a community pharmacist in North Carolina, can you explain how rural and underserved communities are impacted by the closure of independent pharmacies resulting from the consolidation of PBMs and insurers?
Yeah, we are already starting to experience these pharmacy deserts, and we're seeing it in rural areas because of they're driven to close because the reimbursement model, they can't remain open. And where you have these pharmacy deserts, you have increase in cost, and the increase in cost comes from delaying care. So the patients who may be newly diagnosed with diabetes, that's getting put off years. So all the damage that would be happening while that patient's going untreated with diabetes is happening. So they show up outside of that zone when they finally do get to a care point. They show up at a higher risk score or a higher or more severe or more progressed disease state, which is a more expensive place to treat them.
Absolutely, and I have to tell you that my state of Alabama, for example, didn't extend Medicaid. And frankly, a lot of the rural hospital closures over the last 10 years have predominantly been in states that did not expand Medicaid. Dr. Rome, with the remainder of my time, can you talk to us about what this consolidation is doing for rural and underserved communities?
Sure. I mean, I think we've talked about consolidation of a lot of different entities in healthcare today, and it's just important to keep in mind that ultimately there's rural communities need access to healthcare. They need access to prescription drugs from their pharmacies. They need access to doctors, and ultimately we need to figure out a way that's equitable, that's fair, to pay for that level of service, and to not design a healthcare system that sort of drives that away.
Absolutely. I yield back the balance of my time.
Pursuant to committee practice, we will now move to 2-to-1 questioning. I now recognize Mr. Hearn, Oklahoma.
Thank you, Mr. Chairman. I really appreciate for hosting this hearing on consolidation in the healthcare industry and for including an old Okie, my dear friend, Glenn Mulready, who's a fellow business leader in Tulsa, and it's great to have you here today, friend. It's good to see you. As most of you know, before coming to Congress, I owned and operated several businesses for 35 years, and during that time, I saw incredible consumer benefits coming from mergers and acquisitions. But I believe the point of this hearing should be to discover at what point is integration unhealthy? At what point does it cease benefiting the patient and the taxpayer? As a free market conservative, there are some key components Congress should adhere to when examining unhealthy consolidation. First, Congress needs to identify which government policies promote unhealthy consolidation, namely through Medicare and Medicaid, and how that wastes the taxpayers' money and reduces beneficiaries' quality of care. Second, if Congress pursues legislative solutions in this space, policies should create more competition in the market for patients, not stymie the growth of entrepreneurs. I mention these two principles because it concerns me that legislative proposals from other health committees in Congress approach consolidation by finding ways to attack industries, not solve problems. This committee should approach this problem by identifying current policies that limit the ability for smaller companies to grow and compete. That's why today and every day I want to get down to what the real issues are. And for this hearing, the question is what policies are limiting competition in the healthcare industry and what policies are creating real value for patients and beneficiaries. As an example, my friend mentioned this early on, what PBM's purpose was. And for instance, as a former business owner, my perspective on the drug supply chain is different from some. Having experienced the working with PBMs long before I got into running for Congress and hearing from the independent pharmacies. But as a McDonald's franchisee with over 1,000 associates for 24 years, we contracted with a large PBM through our national insurance company and saved a significant amount of money on prescriptions. And the PBM's customer is the employer and their employees. I've yet to come across an employer that's expressed concerns to me about the PBMs. So we've got some work to do. And while I'm on that topic, I think I'd be remiss not to mention the hospital ban on competition. We are way overdue to repeal the ban on new physicians-owned hospitals who offer patients more choice and drive down prices through competition. It's time for us in Congress to get to the courage to take on more than just drug pricing, which is only 10% of healthcare spending, by the way. We need to look at which government policies are creating a system where 50% of healthcare spending is driven by our doctors and our hospitals. We know that hospital consolidation in marketplaces is anywhere overnight, driven prices 25 to 75% increases overnight, not over a period of 10 years, overnight. And we've got to get down to that. Fortunately, Glenn and I live in an area where we have a lot of competition in the hospital space, but that's just not so across America. And we need to take a look at that and see how we get back into a free market, competitive space. And I would argue one of those ways is physician-owned hospitals. And we need to remove that ban. And Glenn, you and I spent 22 years in the healthcare industry. Your testimony highlights the impact of hospital consolidation on Oklahoma, specifically in rural areas, of which we have many rural areas in Oklahoma. What are some of the policies we should explore to increase competition in this sector? If you could help us out there, that'd be great.
Thank you. Thank you for the question, Congressman. I think you've heard about it with this panel a number of times here this afternoon, but the facility fees being charged and for, certainly in my opinion, no additional benefit with physician offices versus outpatient. We have seen facility fees of anywhere between $300 to $1,500. Same service being provided in an outpatient setting versus a physician. I'm not saying we do away with facility fees. Those are appropriate in the appropriate setting. I mean, the original idea of that was to take care of some of those issues that hospitals encounter, right? Standby personnel, NICU units, things like that. We don't want to throw that baby out with the bathwater, if you will, but I think we do need to look at some site neutrality is the key issue, but without throwing that whole thing out.
I appreciate that. You know, a hospital will buy up their family's physician practice. The next day, the prices will increase overnight, literally overnight. I think it's just unacceptable, and I will tell you that's why today I introduced the Facilitating Accountability and Improved Reimbursements Act, FAIR Act, with Congresswoman Custer to ensure that hospitals have different billing IDs for their off-campus practices so we can identify where those costs are actually being associated. And, you know, over the past decade, the amount of physician practices owned by hospitals that was just talked about have doubled and are increasing to create a problem and lack of competition in our area. Mr. Chairman, again, I thank you for this hearing, and I yield back.
I now recognize Ms. Miller, West Virginia.
Thank you, Mr. Chairman. Thank you all for being here. And speaking of throwing the baby out with the bathwater, 44 years ago, I became a new mother. I didn't know much, as most new mothers don't. And when my second son arrived about 3 years later, I knew a lot more. And I would call my family pharmacist, Mr. Moose, before I'd called the doctor. Because sometimes the questions that mothers ask, you don't really need the doctor. You need to know what the pharmacist knows. And so I always appreciated, he was just right around the block. And he could answer questions that I had over sometimes silly things and sometimes over medicine. But what I really want to talk to you about is how troubled I am with the rapid market consolidation in healthcare. And we're just seeing way too much of that in West Virginia. Part of the hospital consolidations that we're seeing is a function of our rural hospitals are having to choose between closing their doors or selling their practice to a large healthcare system. And while I'm sympathetic to the difficult choices rural hospitals often have to make in order to maintain access for care for patients, I really wish they didn't have to be in that position. We need to empower our rural hospitals to be able to provide care for the most vulnerable populations, such as most of my constituents in southern West Virginia. I introduced the Assistant for Rural Community Hospitals Act last year alongside Representative Sewell that would have extended the Medicare dependent hospital and Medicare low volume hospital price adjustments for 5 years. These two programs provide critical assistance to rural hospitals and allow more hospitals to keep their doors open, particularly in southern West Virginia. We were able to get these programs extended through 2024, but more work needs to be done. And I look forward to working with Representative Sewell on extending these programs further to provide certainty for our hospitals. Now, on to consolidations in the PBM market. One of my top priorities is improving care for patients in end-stage renal disease. We have a lot of that in West Virginia. And I've heard from a pharmacist in my district recently that kidney transplant patients are having trouble accessing the immunosuppressive drugs that they need to keep their transplant viable. PBMs consider anti-rejection drugs to be specifically specialty drugs, and that they require the drugs to be mail-ordered from their own specialty pharmacies. I'm not sure if you all have been to West Virginia, but it's not like living in Kansas. The mountains make it extremely difficult for mail to be delivered, sometimes in a timely manner. And transplant patients cannot go without these drugs for even a day for fear of transplant rejection. Patients in rural communities need to be able to get their drugs from their community pharmacists. My state has been a leader in reforms that would tackle some of these PBM issues. In West Virginia, PBMs must have a mix of brick and mortar pharmacy options and mail order. 100% mail order drugs are not permitted. Price cannot be used to determine whether a drug is a specialty drug, and all rebates must be passed through to the consumer at the point of sale. And if for some reason they can't be, they must be sent to the plan and used to lower the plan's rate for the next year. While I understand that not all of these reforms might be practical on a national scale, I really think that they're a good place to start. Commissioner Mulready, Oklahoma, like my state, has been a leader in reforming PBM practices. Can you elaborate on the positive impacts for patients from Oklahoma's reforms? And have there been any negative impacts or missed opportunities that you'd like to comment on?
Thank you for the question. Our bill that was passed in 2019 was called the Patient Pharmacy Choice Act. I think the key word there is choice. And so that our bill in the state of Oklahoma has focused on choice and patients having the ability to choose where and when they get their prescriptions. I mentioned earlier the transaction fees are outlawed in our state, and some of the things you've just mentioned as well. I think something additional that could be done, and I think it was Mr. Kelly that had a presentation up there previously, is on transparency and with the contracts with PBMs, with the employers that they are contracting with, just in a more full, transparent manner. In the Affordable Care Act, we came out with a benefit summary, right, that every plan has to utilize that same format, much like the analogy of the window sticker. I think with employers that would be extremely helpful in future legislation, but transparency is key.
Thank you. I'm sorry I've got more questions, but I've run out of time. I yield back.
I now recognize Ms. Chu, California.
Dr. Rome, I want to start on an issue that you touched on in your testimony, that the average prices for brand name drugs are twice as high in the United States compared to other countries. I can tell you there's no other issue in healthcare that I hear about more from my constituents than the skyrocketing costs of prescription drugs. Year after year, drug companies are setting prices so high that they are simply beyond the reach of patients. And you use the example of Humira, an anti-inflammatory medication used to treat rheumatoid arthritis, which increased in price by 470% from 2003 to 2021. and in 2018, Humira made more revenue than every NFL team combined. Well, Dr. Rome, you referred to what other countries do to keep drug prices low. I am proud that in the Inflation Reduction Act, we did allow Medicare to begin negotiating the prices for the costliest drugs out there. Is this in line with what other countries do? Will it bring down the cost of new drugs and ultimately lower health costs for patients? And would expanding those provisions beyond Medicare help more Americans? Also, do these other countries have PBMs?
Thank you for the question, Congresswoman. I do think that the Inflation Reduction Act and the Medicare negotiation provisions are a step in the right direction. Even under the Inflation Reduction Act's new policy, Medicare is prohibited from negotiating from drugs for the first 9 years or 13 years that they're on the market. And so the pharmaceutical industry will still be able to set high prices for those periods of time. Most other countries negotiate at the time that drugs enter the market. This includes most of our peer countries in Europe, in Canada, and they do so by examining how well the drug works, looking at the prices of what's already out there, and making sure that the price is fair. And this allows then the healthcare system to use those products, aligned with value and aligned with good patient care. So we do have a way to go to get towards that.
And do they have PBMs?
That's a good question. I would yield to somebody with knowledge of this if they know if there's PBMs in other countries. There's definitely some intermediaries that are making these decisions and health insurers, but I don't know if there's specific PBMs.
Well, I would like to ask then, going to another thing that you raised, which was generics. That the generics are used as a way to manipulate the system to keep the costs high. For example, the drug maker Teva introduced a new version of its multiple sclerosis medication that could be injected 3 times weekly instead of once a day. This means generic competition was delayed by more than 2 years, which resulted in billions of dollars of profits for the company, paid for in the backs of patients and the taxpayer. So how does delaying generic drugs from coming to the market impact patients, and what changes have to be made to stop this manipulation?
Thank you for the question. Lots of changes need to be made to make sure that the drug industry isn't able to manipulate existing rules like patents and extend their monopoly periods. Competition works in the pharmaceutical industry. It works for generics. Prices do go down, usually very quickly, by up to 80% if there's effective competition. Many products that could have generic competition don't have enough generic competition. And for brand name drugs, companies use any strategy they can to extend the period of monopoly before competition begins, because that's the period of time when they can make money. We just saw Humira finally face its first competitor this year after 2 decades, and after many, filing basically thickets of dozens of patents to protect that product. So if we can tackle that problem and we can get competition to the market sooner for some of these products, we would see prices come down.
And just to put a number on that, the top 12 best-selling drugs in this country have over 125 patents that have been filed on them, and the estimate is 38 extra years of exclusivity. And this is a complete game.
And can you say a few words about private equity and its role in keeping prices high?
Sure. I mean, private equity, probably less outside of my area of expertise in terms of the pharmaceutical space. But so maybe somebody else can comment. But in the prescription drug market, I'm not sure private equity is responsible for high prices of prescription drugs. What's responsible?
But in healthcare in general.
Yeah, and I mean in healthcare in general, not my area of expertise. I'll defer to maybe Mr. Rickman can answer, or somebody else can answer if you'd prefer.
Well, I ran out of time. So.
The one thing I would say about private equity that we know is that in general, their time period is between 3 to 5 years in terms of making high yields for their investors. What does it mean for a company to purchase a healthcare hospital or a physician group and turn a giant profit in 3 to 5 years? Is that good for people? No. Is that good for the system? No. Is it good for health? No. So their business model does not align with the interest of the people that are being served by the healthcare sector.
Thank you for that. I yield back.
I now recognize Mr. Fitzpatrick, Pennsylvania.
Thank you, Mr. Chairman. Thank you to all of you for being here. In 2019, patients filled more than 3.7 billion retail prescriptions, and approximately 3/4 of these prescriptions were filled through PBMs. Based on the data our committee has received, three PBMs control 80% of the prescription drug market, and 6 PBMs control 96% of the prescription drug market. My first question for Mr. Moose, PBMs have excluded over 1,300 unique medications from formularies for at least a year, and of this, nearly half are single-source drugs. In your work as a clinical pharmacist, what impact have you seen from this practice on clinical outcomes for your patients?
Yeah, we see this daily. They use the tool called prior authorization. So when the physician sees the patient, determines what the patient needs, writes that prescription, the prescription comes to the pharmacy, it gets rejected at point of sale saying this drug needs to be prior approved. We don't cover it, or it's not on formulary at all. You'll have to choose another drug altogether. Starts the path back again. We have to contact the physician that wrote it, tell them that it needs a prior authorization. They have to jump through hoops saying why they need this drug versus the drug that's on the formulary, or a drug that they get a higher rebate on, or whatever reason they've chosen to not leave that drug or not add that drug to their formulary. What it does, it leaves the patient sitting there in limbo. While all of this is happening, somebody's trying to make a decision on, what medication can we get for that patient while the patient is sitting there in limbo waiting on some option that it was the prescriber's second option.
Mr. Moose, turning to transparency, how can requiring price transparency for PBM practices, such as rebates and fees, help people like you do your job better? And do you believe this would help patients better understand the cost of their drugs and ultimately get better access to medications?
Yeah, the whole transparency thing is we, a lot of times up until recently, we didn't have a clue of what we would even be paid for the drug. But if you use a pricing like NADAC, we know what the drug costs from the wholesaler. We know what the pricing is going to be. So with the Part D plan, surveying pharmacy colleagues of mine, 50 to 65%, that's over half of the prescriptions that are filled for Part D patients, we are filling for less than our acquisition cost of that medication. So we are paying that patient to come in there and let us fill that prescription for them, or paying that PBM or that insurance for that to happen. So that's just not a sustainable model. So having that transparency in there would allow you to see that. Also to have the ability with the PBM to opt out of that drug. If they're not going to go with NADAC pricing and that drug we're underwater in that drug, we can tell the PBM that we won't fill it. But now they bind us contractually to not fill the drug. We have to fill the drug, whether we're losing $1 or $500.
Thank you, Mr. Moose. Mr. Moretti, I just want to get your thoughts on one question. In my district, our community pharmacists have reached out to my office many times to offer their concern about pharmacy benefits, specifically regarding the impact of copays for Medicare beneficiaries. What steps, in your experience, what steps do you think this committee should take, this Congress should take, to further examine the roles that PBMs play in driving up prescription drug costs for patients across the board?
Well, I think you've heard a number of ideas here today. You've got that play between Medicare, state laws that are passed that we've got in Oklahoma that do not apply to Medicare type programs, and the courts have ruled on some of that, still to be played out. But I think some of those same measures could be taken into account that have been done at the state level as would be done federally. I think the question that I would ask or be concerned about would be, when you've got a state like Oklahoma that has taken aggressive steps in regulating PBMs, is how does that interact with what gets passed at the federal level? We wouldn't want to lose any of those measures that have been taking place so far.
Thank you, sir. My time's expired. I yield back, Mr. Chairman.
I now recognize Ms. Tenney, New York.
Thank you, Mr. Chairman, and thank you, Ranking Member. And thank you to our witnesses. All of you have been terrific, and this is a huge issue in my district. I'm from New York, where this is a unique problem. And over the past 30 years, Our healthcare sector has seen an unprecedented number of mergers and acquisitions, and particularly in New York, where a lot of the rural community hospitals are under siege or have closed or can't survive. From 1983 to 2014, we saw the percentage of physicians practicing alone halve, while the percentage moving to practices of 25 or more quadrupled. So we're seeing this consolidation on that level as well. On top of this, and I know everybody's heard this number, but I hear from every one of our local pharmacists that the PBMs that manage the prescription drug insurance company, as we know, only 3 control 80% of the marketplace, and nearly 70% of prescriptions are covered by vertically integrated PBMs, which control their own pharmacy chains. We know these trends are not good for our communities, and I've heard from our local community pharmacists, and I echo the sentiments of Representative Miller. I mean, I had parents who had catastrophic illness, and I cared for them. I lived across the street when my parents were in their final years. And I am grateful to the people at Parkway Drugs, a local community-based pharmacy, for all that they did to help us with their catastrophic illness. My dad was paralyzed in a wheelchair from a dissecting aortic aneurysm that he survived, and he was blind. So he had all kinds of multiple organ failure and issues, and this local pharmacy was phenomenal. And so, Mr. Moose, I'm going to address my question to you. We spent a fortune on drugs, even though my dad was a retired justice, a New York State justice who had access to a top-level plan through the state of New York. So we know that PBMs, I think you'd concede that they can play a role in bringing negotiated prices and lowering them. But in your experience, what can we do to make this balance right? Because I'll tell you, our local pharmacies are stocking their pharmacies with all kinds of consumer goods to make up for the hole that you described earlier. Can you explain to me what we can do to put the PBMs in check, and also to not put our pharmacies into quasi-convenience stores so they can make up for what's happening on the drug market?
Yes, thank you for the question. And it's even getting to the point that the convenience store items are not making up for the losses. So as I mentioned, 50% or more of the claims that we fill for Medicare Part D, we're actually selling at less than they cost us. So that's not sustainable. By having that transparency level in there, the rebates are a great place to start. Rebates drive the cost, whether it's hospital rebates, drug rebates, any of those out there.
How can we implement that? So, like legislatively, is what can we do in Congress? What can we do on the Ways and Means Committee to implement that, to make your life more fair, so you can compete and the PBMs don't dominate and continue this consolidation that drives competition away?
I was talking to a municipality that we fill a lot of prescriptions for, and my average cost for one of the recipients of that insurance was $55 for the prescription. And he laughed and he goes, "You got to be kidding." He said, "My average cost that the PBM charges me for is $89 a prescription." I ask you, where does that delta, where's that difference in price goes to? That goes to the PBM. There's no transparency. They didn't tell the PBM that
How do we get that money back? I mean, can we require that price that delta to not exist? I mean, how do we do that?
They have to report that out. They need.
Okay, so we can actually see that.
They need to show that. There's a point where you say, hey, they're a business too. They deserve to make money, but they don't deserve to extort money from it. If you see what you're paying as a person buying insurance, if you see how much you're paying for that and how much that price is inflated, then you can establish, okay, am I actually getting value for them? Or could I strike a deal as a payer directly with the pharmacies, which is what we try to do on the care side, and cut out that entire middleman there? They don't bring any health care value on it. We've got technology and we've got NADAC pricing. We can do the majority of what PBMs do now. Back when they started back in the day, we didn't have those luxuries.
I just want to say thank you to Mr. Mulready, Commissioner, for all your hard work and for doing this. One quick question, if I can get in with Mr. Richmond. What guardrails would you put on any antitrust reforms to ensure that unscrupulous players in the industry do not continue to bypass the rules? And we know that FTC, the Federal Trade Commission, has somewhat of a checkered past in this. I got about 5 seconds. What would you do?
I got a long answer. Maybe I should just give you your staff some of my writings. I do think that the biggest problem right now in the healthcare space is immunities to antitrust law that are being established by state legislators. But there are lots of other things, even outside those immunities, that we can do under antitrust law.
Great, thank you. I appreciate all of your time and all of your expertise. I yield back.
I now recognize Mr. Evans, Pennsylvania.
Thank you, Mr. Chairman. Thanks to the Affordable Care Act, more Americans have health care than ever before. The most recent passed Inflation Reduction Act extended the ACA premium tax credit created under the American Rescue Plan until 2025. These tax credits allow more than 8,000 Philadelphians in my district to newly enroll health care plans under ACA and save hundreds of dollars per year in health care premiums. Mr. Isaac, can you speak to how these potential cuts would impact the impressive gains we have made in the ability for individuals to access care?
Thank you very much, Mr. Evans, for the question. I was born in Philadelphia, so it's wonderful to get it from you. At the end of the day, you've got it just right. We have done a yeoman's work to provide health insurance to Americans. We're at the lowest rate of uninsurance in the country in the history of the nation. The Inflation Reduction Act increased subsidies to make sure that health care was affordable for all families that receive coverage through the exchanges. At the end of the day, what we hear today is that health care affordability is a crisis, right? It's a crisis for the federal government, it's a crisis for state governments, it's a crisis for employers who are paying for it. What we can't do is put that crisis on the backs of America's families. We cannot repeal the support through the exchanges for affordable health care. We have to tackle the problem itself, which is anti-competitive behaviors. It's monopolistic pricing, things like that. That's what we have to do. And the other thing I was going to point out is the Inflation Reduction Act also did something very important. It finally allowed the federal government to negotiate a fair price from drug companies, and then it used those savings to do things like cap the amount of money that a senior would have to pay for their drugs in Medicare. So it reinvested the savings to make healthcare more affordable. That's the kind of reforms we need.
Are you optimistic?
I am very optimistic. I think the American people, what we know for sure is that during COVID, we saw the largest decrease in employer-sponsored coverage in the history of this country. More people lost health insurance than ever in the history of this country because the economy came to a grinding halt. And guess what? People's access to coverage was maintained. The only place where we saw people lose health insurance coverage on net were the states that refused to extend Medicaid to their most vulnerable people. The structure of the Affordable Care Act works. It protected people during the pandemic. People expect that now from this country, and I think we're in a really solid place, and we've got to keep that success going.
I thank you, Mr. Chairman. You yield back the balance of my time.
I now recognize Mr. Moore, Utah.
Thank you, Chairman. The Congressional Budget Office forecasts that the Medicare Hospital Insurance Trust Fund will be depleted by 2033, reducing benefits for Medicare beneficiaries. However, this projection only represents a fraction of Medicare's financial challenges. The sections of Medicare covering physicians and medications are on track to face a shortfall of $447 billion this year. That's predicted to exceed $1 trillion within the decade. I was a little more emotional yesterday. I think my voice was raised when I made the point that expenditures are escalating at an unsustainable rate, and that rather than everything we tend to do just redistributes the financial burden. We must focus on reducing costs. That is the point where we're at now. There are no more easy decisions with respect to how we go about doing this. We have to reduce costs. If we don't, we'll continue to do what we've done, and small businesses and Americans will continue to pay an outsized portion of their percentage of their own individual budgets towards health care. Promoting competition is a viable strategy to achieve this, and there's so many different ways, and there really is innovative groups out there that are trying to tackle this, right? And they're doing it far better than what us members of Congress are probably even allowing them to do, and I encourage us to constantly take a look at that. Professor Richmond, you mentioned in your testimony that consolidation is leading to higher expenditures for federal programs and creating unsustainable burdens on federal and state budgets. You also provided a ray of hope by indicating that new, innovative practice models could disrupt these consolidated markets and help reduce costs. Can you expand on how these innovative models could lead to cost savings and promote value-based care.
Yeah, thank you, Congressman. There are a number of different proven delivery systems that have proven to bring costs down. I think the one commonality across all of them is that they're not run by hospitals. And there's a very simple logic behind that. If a hospital manages a health system, to a large degree, their revenue model depends on filling the hospital. If you're a physician group, an independent physician group, whether you have an insurance product with you or not, your business model is all about keeping people out of the hospital. Not only is it a more cost-effective model, but frankly, it's also more consistent, more aligned with the interests of the patient, about maintaining health for long-term perspectives and investing in preventative care. So one observation is that there are a lot of creative models out there. The second observation is that it's extremely difficult to foster those models if hospitals are controlling all of the inputs, all of the referral flows. And that's one of the biggest problems with hospitals purchasing physician practices. It's not just that there are automatic price increases because of consolidation. It also cements the hospital at the epicenter of the health system and precludes exactly the kind of innovation that you're describing. I will say also, it is true that 3 PBMs dominate 80% of the market. That is a high degree of concentration. There are economic problems with that. But give me a hospital market with 3 options. If you have a hospital market, and by the way, hospital expenditures is twice that of pharmaceuticals. If you give me a hospital market with 3 options, I think you can see a lot of the innovation that you're describing that really would benefit care and critically bring costs down.
Yeah, I think you speak to value-based care better than most, and I appreciate that approach. And I would argue that hospitals they truly do want to care for patients. They do want the best in mind, and they'll adjust. We'll make adjustments as we go through this, but we have to figure out a way to target those costs. And there will still be a market for this. There absolutely will be. Mr. Moose, in your testimony, you discussed how direct and indirect remuneration fees strain your business. Last year, CMS proposed a rule to forbid these fees in Medicare Part D. Do you anticipate this rule will alleviate the burden of DIR fees by moving the collection of fees up front?
No. They didn't do away with the fee. They didn't make where the fee came from or how much the fee could be. That's all still determined by the PBM. They just are telling me how much they're going to take up front as opposed to telling me after the fact how much they took. So it's still there. We've seen the rates. We've seen what the contracts look like. They're worse this year than they are previously. And put that on top of the fact that in the first quarter of 2024, not only will they be taking the fee, they'll be taking the 2023 fees out too. So we'll be getting double taken away in that first quarter of 2024.
Thank you so much. Thank you for your time. Appreciate it, Chairman. Yield back.
I now recognize Ms. Steele from California.
Thank you, Chairman Buchanan, and thank you all the witnesses for today's participating for this meeting. We should all agree that transparency in healthcare is an important step to addressing rising costs of prescription drugs for the patients. I believe we need greater transparency throughout the pharmaceutical distribution system, and there must be clarified on the potential of artificial inflating list prices. That includes greater understanding of pharmacy benefit manager, PBM, rebate process for the public to analyze, as well as ensuring PBM business practices are not blocking patients' access to competing lower cost drugs for my constituents. My question to Mr. Moose, that PBMs are increasingly owning pharmacies, and nearly 70% of the prescriptions filled are covered by a vertically integrated PBM. Can you elaborate on how this vertical integration has impacted Moose Pharmacy and your competitiveness to serve your patient? And do any of these practices result in patients spending more out of pocket And before you answer that, you try to answer under the Congresswoman Chu's question that other countries have PBMs in their countries. I thought I saw you that you were about to answer, and then we went to another question. So if you know, just yes or no before you.
It's my understanding that we pay the most in the world for drugs, and we are the only country that has a PBM managing that for us.
Thank you for that answer. And could you answer my questions?
Yes, so vertical integration, how it affects me day to day is, well, it starts when you get your insurance card in the mail. And you open that envelope, and you pull out your insurance card, and it says CVS Care Mart on it. So most consumers think, well, I've got great insurance, but I can only use it at what's on the card. So they feel that, first of all, that they're forced to change to one of those pharmacies. But when they come into my pharmacy and we're not in network, that means they have to go to a pharmacy outside of us that is in network. And one of the practices that's done, and this is kind of driven by this DIR thing, is, you know, DIR was put in place to increase the quality of the pharmacy and to measure quality and to make sure that patients got the highest quality pharmacies. And you would get a bonus if your pharmacy quality, if you were meeting metrics. But the PBMs were really good at turning that around from a bonus to a takeaway, and not necessarily based on true quality. So that same patient that walked in my pharmacy couldn't get their medication there, but they could go to another pharmacy that was in network, get the medication, and maybe they give that patient a 90-day supply. Well, if you're on one drug and you're fairly healthy, maybe you need something for ADHD and you're fairly healthy and you go there and get that drug, that's fine. Because some patients just need a drug, but some patients need a pharmacist. Right. And some patients need a pharmacy. And those are the patients that are hurt. The patient I spoke of earlier with diabetes, hypertension, lipid problems needs a relationship with a pharmacy that they can have a face-to-face with. So they go to that pharmacy, they tell them that they're going to give them a 90-day supply, so there's less communication. Now it's once every 3 months as opposed to monthly or maybe multiple times a month. Our data says a complex patient in North Carolina sees their primary care physician 3.5 times a year. They see their community pharmacist 35 times a year. So we're leveraging all of those touch points to get a better outcome for that patient. But they're making that patient get a 90-day supply so they can check the box on the DIR thing and not get dinged on that. So the DIR is there to serve them to check the box to get higher payment, not to help the patient. So we're actually doing a disservice to the patient by allowing that to happen.
Thank you very much. Mr. Chairman, I have more questions, but my time is almost up, so I'm going to do in writing for the record.
Thank you.
I yield back.
Yeah. I now recognize Mr. Davis, Illinois.
Thank you, Mr. Chairman, and let me thank you and the ranking member for these very profound discussions that we've been having relative to health care. I also want to agree and thank all of the witnesses and agree with my colleagues who've suggested that these are very difficult and complex issues. I'm thinking of my own engagement relative to health. And ever since I've been paying attention, we've been talking about how do we reduce the costs. And that's since the late 1960s and early 1970s. And I don't think we've been able to do so yet. We've tried everything that you can think of. We've made some progress. And we do have a very decent system. But notwithstanding everything that we've tried, we still have not come to the point where we agree and think we ought to be. And so when I'm engaged in these discussions, I'm often wondering, what do we really expect to accomplish? What are we really trying to do. And I know individuals who suggest that we do fairly well in health care, but we're really dealing with sickness care and not the overall health care in a sense of the word that many public health experts would suggest that we ought to be. And I guess that's one of the reasons that I believe that what we really need is a national health plan, Medicare for all, a plan that everybody is in and nobody is out. Because when I think of my own community, where life expectancy in one area might be in the 90s, in another area a few miles away, it's in the 60s. Are we trying to reduce the disparities that exist? Are we trying to get at this question of what life expectancy ought to be? There's a guy in the community where I live, we call him Dr. No. And he often says that if you keep doing the same things that you've always done, you're going to keep getting the same results that you've always got. And he also says that you can't get blood out of a turnip. You can squeeze it, you can tease it, you can stick holes in it, but you're still going to get turnip juice. Dr. Rome, let me ask you, are you suggesting in your testimony that we need to have a far more aggressive system of negotiating with the pharmaceutical world as one way of reducing the price of drugs that we use? Another part of that, but go ahead with that, and that's going to take up all of my time.
Yes, I mean, I do think we need more aggressive ways of negotiating prices with drug manufacturers. Other countries that do that achieve prices that are half of what we pay in the United States for the same brand name drugs. We've talked about a lot of complex issues. I agree with you that here today. Just keep in mind that 10% of brand name drugs make up 90% of spending. So it's a small fraction of the fills. We're talking about the fills through PBMs that are making up most of the spending. That's where we need to target. That's where the issues of monopoly pricing are really causing problems. Once we have generic competition, all this complexity around PBMs we can talk about. So we do need to do a lot of things, but certainly that is at the root of the problem. That 90% of the dollars are spent on these brand name drugs. We need to negotiate the prices better.
Thank you, and thank you, Mr. Chairman. I yield back and keep these hearings coming.
Yeah, we will. I now recognize Mr. Pasquarello from New Jersey.
I'd like to start off with a question to Mr. Isasi. In my hometown, I was listening very carefully to Mr. Moore's questions, which were very on target. In my hometown of Paterson, New Jersey, the median wage for a family of three is $49,701. A two-bedroom apartment is about $1,800 a month. 20% of the people who live in the city I've lived in all my life, under 65, do not have health insurance. So what do you think Congress should pursue to incentivize care delivery in the community at local physician offices and save American families precious dollars? What do you recommend we do?
I'd say, first of all, no family in this country should go bankrupt if their kid needs care, if they need care. So the first thing we have to do is make sure that people have access to healthcare and financial security to do it. So if you've got 20% of the folks in your community who don't have access to health insurance, we got to solve that problem first. That's the first thing we have to do. The second piece is that we have to understand that underneath all of this complexity, the financial incentives that healthcare corporations are responding to are not aligned with the families and the patients that they treat. They are not aligned. They are literally, in many cases, oppositional to their interests. And so we have to address the economic incentives that are driving the waste, that are driving the poor outcomes, that are resulting in the 250,000 people a year who are dying from the system, not from their illnesses, right?
Thank you. Mr. Richmond, in your testimony, I read it, you cite that nearly 3/4 of all physician practices are now owned by corporations or healthcare systems. That's a huge number. Fewer are independently owned and operated by doctors in the community. I'm very concerned about that. I know you are. Why does this statistic concern you? And can you tell me how private equity has driven these consolidation efforts and limited access to community care?
Thanks, Congressman. First of all, I think private equity has accelerated the process. I don't think private equity is necessarily responsible for it. I think what drives it is that because of, in large part because of what Mr. Sassi just said, the incentives that we have in the system are reward inpatient care and inpatient control. Part of it is because we don't have site-neutral payments, but there are other reasons also. The most significant part of your question, to me at least, is why am I concerned about this? I am deeply concerned. I'm deeply concerned for at least 3 reasons. Number one, when physicians are employed by hospital systems, the cost of care is up. It's also lower quality, but it's just higher up. And it's not just because of facility fees. You also have a much more intensive course of treatment. Number two, the direction of care truly is not in the direction of the patient. We get lower quality care if we don't have independent physicians. Number three, we really don't know what the long-term consequences are of diluting physician independence. This is a profession that has been deeply dedicated to research, to patient care. They are thoroughly bound by a code of ethics. And certainly that's not the case for private equity, and I'm not so sure it's true for corporations that employ physicians. I think it's a very, very significant development that really could transform American medicine.
Thank you. Thank you. And I think today's conversation on the state of healthcare affordability is essential and is long overdue. And I thank the chairman for putting us together today. Last Congress, our oversight committee shined a bright light on how private equity's ownership in our healthcare system affects patient safety, consumer costs, and jobs. Thank you all for your testimony today. Thank you, Mr. Chairman, for putting us together.
Thank you. I now recognize Mr. Snyder, Illinois.
Thank you, Chairman Buchanan. I want to thank you and the ranking member for calling this hearing to discuss why health care is unaffordable for so many people in the United States. I want to thank the witnesses for your patience and endurance. It looks like I'm last, which I believe means I get to go until 5 p.m. Not least, but no. Thank you, and I'll try to make the most of my 5 minutes. When I came to Congress more than a decade ago now, the goal was clear. Get more people with access to quality care, get them the insurance they need, increase their access to doctors they can trust when they need it, where they are, lower the cost of prescription drugs. I'm proud to say that more Americans than ever have health insurance, and for the first time in history, Medicare will have the ability to negotiate lower prescription drug prices thanks to the Inflation Reduction Act. And yet, American life expectancy, remarkably, is on the decline. And I'm seeing the nodding heads. I have a hard time getting my head around the fact that in my lifetime, we are seeing not a constant increase in life expectancy, but seem to have peaked, which I hope is an aberration and we can turn that curve back. A quarter of U.S. adults say that they have difficulty affording their medications. In fact, 30% are skipping pills due to the cost of their medicines. No one's contending with a new cancer diagnosis or facing chronic pain or recovering from surgery should be put in the position of deciding whether or not to ration their medicines or pay their bills. Now, while we're at the forefront of global healthcare innovation, and a lot of this innovation takes place in my district, and drug development in this country is something we can be very proud of, the American people who rely on these drugs continue to lack access. What I tell people is a great innovation is only art unless it gets to the hands of the people who need it. The question is why, with so much of every dollar being spent on drugs going to PBMs, wholesalers, and so on, it seems patients are getting the short end of the stick, either paying too much or skipping medications altogether. So Dr. Rome, let me ask you, you talk about how PBMs negotiate rebates to offset manufacturer list prices, but that those savings often don't get passed down to patients as lower out-of-pocket costs. At times you say PBMs even charge insurance plans and patients more than they pay pharmacies. And Mr. Moose, I've heard you talk about that as well. How common are these practices? Do we even know what cost savings, if any, is typically making it all the way to the patients at the time they pay their bills? And are there specific disclosures you think should be required?
Yeah, thank you, Congressman, for the question. The rebates have grown substantially. As the prices of brand name drugs have gone up, rebates have gone up and partially offset that. So now that in Medicare, rebates are 37% in 2018, offset 37% of spending in Medicare. So, this is a game back and forth between the PBMs and the manufacturers, and patients, as you said, are stuck in the middle. It is very common for patients to pay list prices or pay either deductibles or co-insurance based on list prices. We did a study of several dozen drugs, and about half of patients were paying co-insurance or deductibles, where basically as soon as the manufacturer raised prices, their out-of-pocket costs went up directly proportional to that. So that's a problem. We absolutely need better transparency over those rebates so we know where they are, and it's not okay practice. We want the PBMs to be able to negotiate, but we don't want them to be able to pass those costs on to the patient in a way that's unfair based on a price that they're not paying attention to.
So last year I spent not an insignificant amount of time trying to peel back or open up the black box, trying to dig in, understand it, peeled layer after layer after layer, and still ended up with a black box. From your perspective, and I'll ask anyone else, are there things we should be trying to peel back to understand how this system works? Because it's not just confusing to patients. I think it's confusing to almost everyone who tries to look at it.
Yeah, so we should definitely peel back the curtains on what those rebates cost. We should peel back and understand how much, especially in the generic space, how much the drugs cost. There, the prices are even more out of sync, where the list prices don't really mean anything in that space. So we absolutely need more transparency. We need, on all levels. As a researcher, I struggle with this every day too. I try to do research on prices that aren't available. So.
And just to be really clear about what we're talking about, because I think most people don't realize this. If you owned a business and you paid for a PBM to negotiate a drug price for you, it was employer-sponsored, you're covering all the costs, right? Right now, you can't know what did the PBM actually pay and what rebates were flowing. You don't have that information as an employer who's footing the bill. That's what we're talking about. Those arrangements must be understood. The second piece, which was also in your question, is when you're saying that the list price is what's being charged. Just to be really clear, the list price is $100, say, but the PBM negotiates the drug for $20. When your employee walks in or the Medicare beneficiary walks in the door, they're getting charged cost sharing for $100. Right? That's crazy. That has to end.
Right. Thank you, and we need more transparency. Mr. Chairman, we need more time, but I thank you both, the Chair and the Ranking Member, for this hearing. I think it's critically important. I look forward to continuing our work together to address this challenge.
Thanks. Well, I want to thank you, but I didn't ask as many questions up front, but now that I've got you, because I want to get off in a little bit different direction, because you all have expertise in given areas, and something we don't talk about enough. Personally, this is my own feeling. As chairman of this subcommittee, we got a factor of 40% obesity in our country. We're spending $700 billion in Medicare. Obesity leads to type 2 diabetics. I don't think you got enough. They say in terms of Medicare, is only good for another 4 or 5 years because we're going to run out of money. I don't think if people don't take more responsibility, some can or won't, maybe have other issues, but we have to figure a way to get more into preventative care. I had a doctor when I first kind of moved from Michigan to Florida, and he was telling me the story about he picks up a lot of people, 60, 70 years old, 80 years old, moving to Florida as a private practice type thing. And they come in, they're on 6, 7 pills. They're got, a lot of different issues. And he tells them, he said, they'll have a consultation. The doctor will say, do you want to get off half the pills or 2/3 of them? He says, what are you talking about? I can't get on these pills. I've been off them. I've been on them for 10, 15 years, and I understand some of that too. And he says, well, what are you talking about? He says, well, I want you to start walking a mile or 2 a day for 5 days, and I want you to get on a little bit more of a reasonable diet, eat more vegetables, and a little less of everything else. And he said, I'll start to take you off half these pills that you're on. And I think there's a lot said for that. What are we doing about talking about preventative medicine, people being CEO of their own health? And you can eliminate a lot of that. A lot of this stuff that I see is a lifestyle situation. Now, part of it is, and people don't want to hear it, but I think it's the quality of our food. It's heavily, heavily over-processed. And so it's not anybody's fault in the sense that way. But makes a lot of sense. I have one guy, it's an author, I can't think of the name of the book, but changed my thinking on everything. He had an equation that he had in this book, and you get out there, you can get it, I'll get you the name if you want it. But he had an equation, and the equation at the top of the line was the nutritional value of the food that you're eating. For example, spinach, kale, some of those things. And then underneath it was the calories. I thought, well, that makes a lot of sense. He had every food rated. And I got on that, lost 25 pounds, because, over the years, we're all on yo-yo diets, this one, that one, the best, latest diet. But it changed my whole life. And it was just simply where I made better choices. And I've always been I'm a cyclist now, but I've always done some cycling and stuff. And I'm not just saying myself, but I think there's a lot that could be said for a preventative thing. I'm concerned about children. I've got 9 grandkids, 9, 8, and under. What are we feeding them? What are they getting? You hear about nobody likes to talk about, but 32 ounces of a Coca-Cola or something else. And, there's real issues with that. So I think, fruits and vegetables, and that's why I think Whole Foods done fairly good. And I think a lot of people are moving somewhat more in that direction. But to encourage, not everybody's going to do it. They got to make their own choices. They're an adult. But for their children and I see my daughter-in-law, she's, pretty heavy on that, where you come in, you got a big bowl of fruit sitting out there, and they're giving the kids more vegetables and stuff like that. So my point is, what's your thought on that? I mean, doesn't that have a place? And I just think if it's true, I've been told 40% of the people are obese in the country, take 30, but 30 years ago it was probably 10%. But I think a lot of it is the quality of the food we're eating, and just a combination of all the above. So one of the things I want to go down the road on is preventative care. The second thing is that when you have fee-for-service, you've got to be very careful. As I had 1,200 employees before I got here. You got to be very, very careful about what pay plan you put somebody on. I'm not against the doctors or anybody else, but you have fee-for-service. The tendency is, not that they mean to do it, but the tendency is to do more, you make more. That's not the right incentive you want. My idea is I don't want them to get on the drugs in the first place. They say that if a person has a heart attack, 50% don't see the next day. I don't want to have a heart attack to begin with. And there's a lot of stuff that you could do to minimize a lot of that. So I throw that out because I was just interested in your take on it. That's, I personally believe, is the way we need to be going. As the gentleman said a few minutes ago, that it's kind of surprising his lifetime with, people aren't living longer. That we should, ideally, because we've got opportunities out there. So I just kind of throw that out. That's where my thinking is, because it's applicable in my life, but a lot of other people's lives. And but I realize it's a choice. Can't tell anything, but I got to tell you, I took my kids to the fairground the other day, my grandkids, and I hadn't been there in a long time. I'm a blue-collar kid that grew up. These are my people out there, a lot of them. I look around, and 90%, 80% got to be 50 to 100 pounds overweight. Now, I don't want to be judgmental, but the point is, do we have enough money to take care of all the people that are sick as a result of processed foods and everything else? And we're not going to get everybody off it, but we could get some off of it and start moving in that direction, because we're spending we collectively add up what the government spend $1 trillion a year. You just can't keep spending money like that unless we make some changes in our own behavior, I think, as a country. And I think we're as high as anybody in the world in terms of the obesity, but yet we spend this year $4.3 trillion in health care, and we're the sickest. It doesn't add up. So let me just throw it out to you, just because we've talked about other things, but I didn't want to start the meeting this way, because some people say, Vern, where are you going with all this? But I do want to kind of get your thoughts on, briefly give everybody a minute or two or whatever.
Mr. Chairman, thank you for bringing that up, something I would like to have talked more about in this session. I think you've heard a lot from here about transparency, but I think a lot that goes along with that is consumer engagement, which is a lot what you're talking about. And I think we've seen that play out well with restaurants and menus, things listing out the calories, that sort of thing. Part of the problem with the opaque world of healthcare, I could go online when this meeting ends and learn more about replacing my $200 watch than I can about a $15,000 medical procedure and making decisions on how to go along with that. We've made some improvements, but there's a lot that could be done within that space. I think the other issue that you deal with here is I have three sons, 19 to 23 years old, and I've used this example with them. When you go out to eat and you're looking at the menu, you just look at that differently. It's human nature if you're paying or if there's a third party paying. It's just human nature, and I think you're dealing with that issue as well here, is that transparency and a third party payer system.
Yeah.
Thank you.
Anybody, what I'm talking about is being the CEO of your own health. Taking responsibility. So let's I'll give everybody 2 minutes, and
Sure.
if you want it.
So, and Chairman, great question, and I do have to say, I think that when you look at the literature on this, you put your finger right on a very serious problem that we're facing as a nation that has economic consequences, and it has consequences for people's happiness and ability to thrive. Just to start kind of in reverse order, fee-for-service, I just want to say this really clearly. In part, what you're describing is a problem that fee-for-service has created. We do not have a system that incentivizes the healthcare sector to make us healthy, right? It's a sick system that is basically built off what's the highest margin procedure I can do, and I'm going to just crank away at that thing and make money. And so the new payment models that are being explored at the Centers for Medicare and Medicaid Innovation, the risk-based payments, it's about saying to a group of doctors or a community of providers, you keep these people healthy and you get them healthy if they get sick efficiently, and you're going to make money from doing that, not from bottom.
You've got to set up the right pay plan, the right incentive.
Right, that's the
For
first
me,
thing.
In companies that I've had, the most important thing was getting the pay plan right. Go ahead.
That's right. That's the first thing. We've got to get these incentives right that go into the healthcare sector. The second thing is on preventative care. I did a lot of this work with the governors when I was running healthcare at National Governors Association. And it was this really basic concept. There's so much waste in the system right now. And so we helped governors looked around and saw that there were communities where they were spending too much time in the emergency room, right? And what did they figure out? They figured out they closed a clinic after hours that people needed to use. They reopened it. They saved money. And so there was this basic principle. When we save money by pulling waste out of the system, let's take a percentage of that, like 10%, and invest it upstream to actually address the reasons people were going to the emergency room. Things like, so the idea of making a link in all of this work we need to do in the next decade to drive waste out of healthcare, how do we find a portion of that and reinvest it to prevent the health problems that we're having? The third idea was, there's a lot of literature in public health. I come from a public health background about why people make decisions and how people live a healthy life. Part of it is knowledge, right? And you're describing when you actually looked at that formula and you said, well, wait a second, calories and nutrition, let me find the things that have the greatest ratio of nutrition for calories. That's knowledge. But then the second piece is, what does the community around you support? What is the environment that you're operating in? Just that knowledge itself isn't enough. And then the third is instrumental. Like, do I have fresh fruits and vegetables in my community? Can I get to the store, right? We have to hit all three things if we really want to change people's behavior. It's not just knowledge.
And I'm saying we can pay for all that because people won't be as sick.
That's right.
From
That's
that
right.
standpoint.
That's right.
I want to, Dr. Rome, why don't you,
Sure,
just
no,
your thought. I'm just.
Yeah, I'll be quick, and just because we've been here a while, but I do think, I mean, I'm a primary care doctor. I spend time in the rooms with patients, and I spend a good portion of my time talking about exactly the topics that you're talking about, which is, sort of how to keep them healthier, how to keep them away from me, and away from the hospital system that I work in. And so it's absolutely, crucial. We also have, there are a lot of barriers that patients face in those things. I have patients who run out of food at the end of the month. I have patients who don't have a stable housing. So we have a lot of social problems that we need to we separate, and we think about healthcare spending versus everything else. But on this committee, you think about spending on everything, and maybe we ought to think about the way we're financing healthcare, the way that we're thinking about health, and redefine it more broadly the way you're talking about. If we can invest in those social support services, maybe we can
I would say
you'll
have more money for those support services. We won't be spending it on everybody
I agree.
else.
Yeah.
Mr. Moose, anything you want to add?
I think the key word is an investment here. We have to look at this as a business proposition. There's an ROI for investing dollars up front for better access to high-quality foods, for exercise programs. Somebody who's physically active has less propensity to have behavioral health, mental health issues, saving money on the back end. So we've got to look at it as hey, there's a true ROI. Let's put some money up front for preventative type activities, preventative type services on it, so we can expect the
I think we're in
downstream
big
benefit.
trouble if we don't start figuring out a way to get people more preventative and set up the right incentive. Did you get a chance to?
I'll just say a version of amen in the sense that we spend 1 out of every $5 on healthcare, but that healthcare that we spend money on contributes to maybe 20% of our health outcomes. The other 80% are the things that Frederick was talking about: the environment that we have, the family we have, the social networks we have, and the neighborhoods we live in. Congressman Davis described a 30-year life differential in his district. That's not because of differences in access to healthcare. They're all
and I realize
social determinants.
There's different factors, and but if we can change it 10% or a certain percentage of people being healthier, it would make a big difference for their life, their family, and the community, and everything else.
I think the science is there to suggest of what we can do. Certainly, it would be a much better use of our existing dollars. And to a large degree, it really does require confronting the payment models that we have and recognizing that we're just spending money on the wrong things.
Yeah, you gotta pay for the results you want. And we want a healthier society, not a sicker society. And I think the incentives are all screwed up, personally, myself. They need to be re-looked at. So let me just say in closing, we have received many statements of support for this hearing, and without objection, I will submit this into the record. I'd like to thank our witnesses, so I want to thank all of you. It's been a long day today, so thank you very much, and any more input you give for appearing before us today. Please be advised, members have 2 weeks to submit written questions to answers later in the writing. These questions and your answers will be part of the formal hearing record. With that, the committee stands adjourned. Thank you very much.
Thank you, Vern. Good hearing. Looks like you got time just right, so now the bell.